Sorry, please, can you see my screen now? Can you see my screen?
Yes, we can.
Okay, so just a brief recap that for research method, for research proposal, the various, this area I still want to stress it, is that for us to start off for a good, to write a good proposal, we're expected to read wide in our field and even outside your field. As you do so, you can get inspiration. And then you discuss with your colleagues, and from there you'll be able to locate literature gaps that you want to fill. Okay. So we'll just quickly move to where we stopped last week. Yes. And this was where we stopped. Where to go through this, we said that a sound proposal will have the background. From the background, you are trying to introduce your audience gradually to what talk about the problem statement, in which you want to paint a scenario of a problem that you want to address. From there, we say you should be able to write about the justification of the study, that why is this study necessary? So most of the time when you're writing justification, you'll be using the word, it is important for us to study this work, to do this research, so that we can get this result. So that, and you can also be saying, if we found this, it will help clinical science in this way. If we did not find this, it will help clinical science in this way. So whether it is negative or positive result, you are still advancing science. So that is why whenever you get results, you are not expected to think that use your results will have to be positive for you to advance science. Even if it is negative, you are still advancing science. You are still advancing science. Then we discuss literature review. So when you've done all this, anybody going through your work should be able to have an idea of what exactly you want to study. They should be able to come up to say, oh, this is what the researcher wants to do. So based on all what you've said, you will now encapsulate everything into research question. And your research question should be very much related to your objective and should even be related to your title. If I look at your title, I should be able to even form the research question from your title. So all these are aimed at you being able to be very explicit with all what you want to do. So if you're able to go through all these steps very well, by the time you get to research question, your audience is already getting a good feel of what your research is all about. So for a research question, as I said, we are just turning the major aim of your study into research. So I have an example here in which we say that the research title says relationship between HIV infection and diabetes mellitus. So the research question will just be, what is the relationship between HIV infection and diabetes mellitus? You may be wondering that this is looking so simple. So why am I writing all this? The aim of you putting us through all these steps is so that we will still get clarity from your work. Some people may get what you are doing right from the background. Some may not still get it. You move to justification. From justification, some may get it clearer. Some may get it clearer when you were discussing problem statements. Some it's until they go to literature review. Some it's when you now write the research question. You now say, oh, okay, so this is what this person wants to achieve. So there are different ways of writing it. So for this same question, this same title of relationship between HIV infection and diabetes, your research question may be what is. Maybe start with what is, or it may be, is there a relationship between HIV infection and diabetes? Okay. From research question, it will flow for you to now start talking about research hypothesis. When we get to study design, you discover that there are some study design that doesn't have research hypothesis. If you are dealing with a descriptive study, you don't need a research hypothesis for a descriptive study. But for part 2 work, we want you to always have a study that will have hypothesis. So since we always want you to have a study that will have hypothesis, you should design your study such that it will be able to test hypothesis. And for you to do that, you must be comparing 2 groups minimum. If you don't compare groups, you are not likely to be able to test any hypothesis. Please note that. Because it has happened before, some people will say, oh, I just want my work to be simple. I don't want stress for my life. Then after collecting that data, they will now come back to the statistician and say, please, statistician, can you just give us 1 p-value? We want at least 1 p-value. I don't like the way all the work is that there is no p-value in my work. And the statistician will now turn to them and say, from this study, from your hypothesis, from your objectives, you didn't compare anything. And if you don't compare anything, you are not likely to have a research. You are not likely to have an hypothesis. So please sit down with a statistician when you are starting off, and that hypothesis will be able to help you to develop. Having a full statistics class, as we always do, we usually define some terminologies, like defining confidence interval, defining confidence interval, and defining confidence interval, defining p-value. But because this is just giving us a broad view of research methods, we may not be able to define those terminologies, okay? But at least for p-value, because we mentioned it, well, after discussing the hypothesis, I will just define a p-value for us, okay? Now, as you can see on the screen, we say that an hypothesis is a testable statement on the proposed relationship between 2 or more variables. Okay? You've written your research question, which is, what is the relationship between HIV infection and diabetes mellitus? When you write this research question, there are 2 things you must ask yourself. What is my outcome? And what is my explanatory variable or independent variable? Here, my outcome is diabetes mellitus, because we feel that it is the HIV that is causing the diabetes. So if it is the HIV that is causing diabetes, that means diabetes mellitus is the outcome. And this outcome is also called dependent variable. This outcome is also called dependent variable. Okay? Whereas the HIV is called the independent variable. or explanatory variable, because it is the one that is causing, that we believe will be causing the diabetes mellitus. Okay. So I just want us to revise this before we now come here. So for an hypothesis, you must have a dependent variable, which is also called outcome, and you also have the independent variable. Based on that research question, the independent variable is the HIV, and the dependent variable, which is the outcome, is the gestational diabetes. People used to mix them up. So from today, please, I want you to get it right away, that the dependent variable is also known as the outcome. And that outcome will be dependent on the what? On the independent variable. So we get that. Okay. So your hypothesis in exam, they used to ask these questions. So please note your hypothesis. They say, what is the hypothesis you are testing? You've written all these tests, everything. What exactly are you testing? What is the hypothesis you are testing? And all the bivariate analysis you are doing it to test this hypothesis. So it's the foundation of your work. Please, we'll be showing you some hypotheses. Please don't have more than 2 hypotheses, because the more hypotheses you have, the more problems you can run into, because you must show that you've tested each of them and you've come to your conclusion based on those hypotheses. So don't proliferate hypotheses. Go for the overarching hypothesis, the main hypothesis of your work. Okay. Now, when you are writing for proposal, you are expected to state the null hypothesis and the alternate hypothesis. And what is the null hypothesis? Null hypothesis means that you are assuming that there is no relationship between the dependent variable and the independent variable. That's the null. And then the alternate hypothesis is that we are saying that there is a relationship between them. So you will agree with me that what the researchers want to prove is the alternate hypothesis. Because when you started off, what you want to say is that there is a relationship between A and B. That is why you wanted to do the study. To either confirm that there is a relationship or to refute that there is no relationship. So what most researchers want to do, want to confirm or refute, is the alternate hypothesis. So it is the alternate hypothesis that we say there is a relationship. And the null is to say there is no relationship. So it's very easy. So if you are confused, what you can do is state the alternate first, which is what you want to do, and just change the there is A and change it to what there is no relationship. Now, this alternate hypothesis can be 2 types. You can have the 2-tailed hypothesis or the 1-tailed hypothesis. You can have the 2-tailed hypothesis or the 1-tailed. The 2-tailed hypothesis just says that there is an association, there is a relationship, but you don't know what type of relationship. That is 2-tailed. Okay, but if you now say you are certain of the type of relationship between A and B, then your alternate hypothesis is 1-tailed. But I must say that most studies, even if you have an idea of what the relationship is, it is better to just go for 2-tailed. Because when you want to calculate sample size, the common sample size formula we have around, they are for 2-tailed test of hypothesis. But if you insist that you want to use 1-tailed, then you must be wary when you are calculating sample size and ensure that you use sample size for 1-tailed. The sample size for 1-tailed is different from the sample size for 2-tailed. So for this example, we see here that we say that there is an association between HIV and birth weight. Is it that HIV will make the birth weight to increase? Is it that the HIV will make the birth weight to decrease? We don't know. but we know that there is a particular relationship. So if you can establish that there is a particular relationship, then that is two-tailed. But for a one-tailed hypothesis, see how it's written here, that birth weight increased among HIV positive patients. That means HIV positive, HIV infection increases birth weight. That's one thing. We have another one here that says birth weight decreased among HIV positive patients, which means that HIV infection decreases birth weight. So if your hypothesis is now like you are saying it increased it or it decreased it, then it is one tail. Okay, as opposed to two tail, which we are saying there's an association. I don't know whether it's increasing it or it's decreasing it. Please, as we move on, if you have questions, you can just put in the chat box or you can stop us, please. Please note what I stated here, that there is no hypothesis testing for a descriptive study. So please aim beyond descriptive study if you want to test hypothesis, if you want to get p-value. Now, I didn't define p-value in any of the slides, but I want to say it now. Most of us will be writing p-value. In your work, you write p-value. And I always say that if I'm an examiner, you've written p-values all over your work. One of the questions I will always ask is, what is this p-value you've written? What is it? Okay? A p-value is the probability that the null hypothesis will occur. P-value is the probability that the null hypothesis will occur. That the null hypothesis will occur means that there is no relationship between A and B. So what this means is that you will want your p-value to be very small. Because if the p-value is large, that means there is a high probability that there is no relationship. But if the p-value is very low, that means there is a low probability that there is no relationship, which means that there is a relationship. That means there is a high probability that there is a relationship. If you have that the probability of, if the p-value is low, what it translates to is that there is a high probability that there is the alternate hypothesis will occur. So probability that the null will occur is the p-value. So you want the p-value to be very low so that the probability of the null occurring will be very low, and therefore the probability of the alternate occurring will be very high. If you have issues with it, please let me know. You can come back. Now you've defined the third question, hypothesis, and then from hypothesis to what? Aims and objectives. The three of them, including your title, they are very similar. But the reason for making you to write them in the various form and the technical way it should be written is because we want clarity. If you didn't get it well when you are writing one, you get it well when you're writing the second one. So that is the reason. Okay, they are all related. If you know how to write one, you just to tweak to get the second one. Now, aims and objectives. The aim is one word that one statement that is encompassing everything you want to do. And you should be able to reduce all what you want to do into just a statement. And as I always tell people, it is always related to your title. Your aim should be related to your title. Okay? So, for example, the example we'll be using, your aim, the title is to find the relationship between HIV and gestational diabetes in youth, among pregnant women in youth, so something like that. So your aim will be what? It's always a verb. Your aim is action word. It's a to-do word. So your aim will just be what? To determine the relationship or to evaluate the relationship between what? HIV and gestational diabetes mellitus. So you see that all of them, they are related, but you must write them in the technical way. So I will still come back to this. Let's jump a bit to see if we can get some aim. Okay, see aim here. So as I think I hinted when we started, that there are some words that are we should be familiar with when we want to design a study, when we want to state the aim. And one of the commonest one is to determine. Okay, some other ones will be to evaluate, to investigate. Okay, you use potent to do what? Okay, you use potent to do what? All right, so you see this, say to determine the effect of HIV infection on the development of gestational diabetes mellitus among HIV pregnant women. Or here you can see say HIV infected pregnant women at the Lagos University Hospital, Lagos. This same aim can also be written as below, to say to determine the association between HIV infection and gestational diabetes mellitus among pregnant HIV infected Nigerian women. Here is not completed because when you say this, it may mean that you are studying the whole country, which may not be possible for you to do. So since it may not be possible for you to do, you have to still restrict to the location. So you still have to put at Lagos University Hospital, Lagos. So in your aim, we should be able to read your aim and be able to see every aspect of it: the study design, the study population, the location, and all that should be there. Everything should be there. Okay, you should be able to see it. So this is a good way of defining aim, and just make it simple, not long. If they say I should prefer one between the first and the second, aside that I've not added Lagos University to the second one, I will prefer the second one to the first one. The first one appears longer than the second one. Just make it simple for covering everything you want to do. So aim at turning your title to your aim. That's what I advise people. Just aim at it. With practice, you get it right. Now, after you define your aim, we know that to achieve this aim, please, sorry, let me just take just 2 minutes break, please. Let me just take some 2 minutes break, please. Please. If you have questions, you can use that to just send a chat to the box, please. Sorry, please, I'm back. All right, so we've just been able to discuss aim. Therefore, the objectives. Please, when you are writing your objectives, as we said, they are building blocks. So, okay, what are the various tasks you will do for you to be able to achieve that overall aim? The overall aim, if we use this example, is to find a relationship between HIV positive, HIV infection, and gestational diabetes. To conduct such a study, what you have to do is to compare. You compare the rate of GDM, that's gestational diabetes, among people that have HIV and compare it with people that don't have HIV. So if those people that have HIV, if the gestational diabetes is higher in them than gestational diabetes level among those that didn't have HIV, then we can now reasonably say that, oh, perhaps it is the HIV that this other group had that made it higher, that made them have higher prevalence of gestational diabetes. And that is why a study that is descriptive will not be able to answer such a question, research question. If you just recruit only HIV patients and you check their diabetes level, I say, oh, okay, in this group of people that, that have HIV, that 40% of them had gestational diabetes. Then people say, so what? You must compare that 40% with people that didn't have HIV before you can now make sense to say, oh, perhaps it is the HIV that is making these people to have higher value than the other. There is even some things we call confounding. We'll see it later on where you are doing your study design. Okay? Because even that you even recruited those that have HIV and those that didn't have HIV. Okay? And you now tested them to see the prevalence of diabetes in the two groups, does not confirm wholly that it is the HIV that is causing it. There may be some confounding variables, which we'll talk about later. But let's keep it simple. For you to be able to answer that research question, you must recruit two groups. One group with HIV, the other group without HIV. So based on that type of study, that is what will guide you in Hello? Hello? Can I continue?
Yeah, hello, sir. Yeah, you can continue, although there's a question already in the chat box, so I don't know if you want to address it now.
Okay. We have moderating or mediating variables in clinical research. If yes, can you give us examples? Wow, yeah, they are. We have moderating and mediating variables. They are there. Just that, okay, I will keep thinking. I'll keep thinking if we can get any idea before we close. Thank you for that question. Okay, so as I was saying, you will have had an idea on your mind. What are the building blocks? What are the first things I want to do first? And I must confess to you that the simplest specific objective that we always write is to say, to determine or to describe the socio-demographic characteristics of the study population. Because all studies, no matter what, when you are getting to your results section, the first table you have to produce is the social demographic characteristics. So whether you write it as an objective or not, you must still produce it. So because of that, we have that people may just make it their first objective. But if you know you have so many objectives, it is given, so you may not add it. But that's a building block, because you must first know the social demographic characteristics of your study population before you move to other things that will aid your final answer. So that's why most of the time some people will make it their first objective. Now you see some objectives. SMART. What key thing you must note about your objective is that you should be able to subject it to this SMART theory. And which is, it must be specific, not only to you, but to everybody. Please mute yourself or the aim.
I'm trying to mute him.
You can put so many things. Please note that it's possible that you write your objectives and aim to answer those objectives. So let it be specific, simple. Another word for that specific, make it as simple as possible. Then the next is measurable. There are people I've seen very wonderful research questions, research objectives that I wonder from now till all the various statistical analysis, I can't really see anyone that we can use to measure or to analyze such an objective. So if you can't, then you need to restructure the objective for it to be measurable and in quotes, if there is a word like that, analyzable. So we should be able to attach naira and kobo measurement to whatever your objectives are. If they are not, then it's not a quantitative study. Maybe you are working in the realm of qualitative. And for most of the research, yes, you can still do qualitative. You can still do qualitative, but most of your assessors, the skill they have, their skills are in quantitative. But if you want to do qualitative and you are very confident, comfortable with it, you have to just look for a qualitative assessor for it. But in the realm of quantitative studies, where you are dealing with figures, numbers, you must ensure that your objective is measurable. The objective is measurable. Now, the next is achievable. That one they will check from your objective, from your methodology, your time frame, your budget, and all that. For example, if at your level now, you want to start checking the genomic implication of osteosarcoma or osteomyelitis, chronic osteomyelitis, you want to see whether there are some genes related to it. My people, it's a wonderful study, but it may not be achievable at this level. Because to conduct such a genomic study, you will need a very large sample size, and you may be running into a multi-million naira or dollar project, which you may not have such resource. So you may not have the resource, you may not have the time. So that is why achievable is also comes in. You have to check whether that your specific objective is achievable. And then is it reproducible? Can another person reproduce it? And then time bound. So please try your best to include the timing of your study in your objective, so that we'll be sure that, oh, this study is not going to continue ad infinitum, that it will just continue forever. Okay, so let's see some examples of, so please try to, even after some time when you are used to writing it, you may not, you write it and it will still meet up with this. But for the purpose of exams, you can try to see whether what you've written is meeting up with this. Before we go to examples of a good aims and objectives, these are just some of the words that I would suggest you think about when you want to write a good aim and objective. You can say to investigate, to assess, to determine, to correlate, to evaluate, to compare. Of all of them, the one I enjoyed using most is to determine. You know, because you want to still use a word that is potent, that your assessor will know that, oh, okay, this guy wants to do something. Now, when we use the word correlate, we use it loosely to mean relationship, to determine relationship. But in statistics, we reserve correlation to relationship between two continuous variables. For example, age and weight. Age is a continuous variable, weight is a continuous variable. Or height and lipoprotein, maybe low density lipoprotein. Low density lipoprotein is continuous, height is also continuous. So when you have two continuous variables, you can correlate, which means the relationship between two linear variables. But if what you are working with is not, all of them are not linear, please be wary using the word correlate. Yes, you can use it loosely in research, but when you get to analysis, statistical analysis and interpretation, correlation is strictly reserved for the relationship between continuous variables. For example, you won't say the correlation between age and gender. Gender is a categorical variable. Age is a continuous variable. So since you are dealing with continuous variable and categorical variable, what you can do is you can't use the word correlate. You can use relationship, so to find the relationship or association between age and gender. But you cannot say to correlate or to find the correlation between age and gender, because age, yes, is continuous, but gender is categorical. But you can easily say you want to find the relationship between age and height, or you want to correlate between age and height, because age and height, they are both continuous. Why I'm stressing this is people make such mistakes, and at the end of the day, most of the time people don't enjoy it, don't like it. Okay, thank you. So now you see some words here. Please don't use them. To check, to find, to search. The another one that is more common, to explore. When you are using the word explore, your aim is likely to be a qualitative study. In qualitative study, yes, to explore is a very useful terminology, because most of the time you are just up and about everywhere. Okay, so explore can be used there, but for quantitative studies, avoid these words. Try your best to remain within these words. The words are on the left-hand side. Most of the time, we try to, how will I put it? That's why you see the title that was given in this lecture is about ABC. Just keep it simple. Okay? what we are doing now is like the anatomy of proposal writing. That's structures. When you start going outside the structure, you want to reinvent the wheel. Then you start running into troubles. Just keep it simple. Use what others have used. Use the common terminologies, and you are good, and you're fine, and you're safe. Okay, so we've seen this, the aim, how we can define, how we can easily write aim. So now we want to write the specific objectives. Please, when you want to write specific objectives, you must write an opening statement. You see it, I specifically put it there. The specific objectives of this study are, don't just write specific objectives, then you start listing. No, write the opening statement like this. The specific objectives of this study are like that. And that is before they are done. When you've completed the study, you can change this "are" to "were," because you're now writing in past tense. Okay? So, this study, the overall aim, we said, was to get the relationship between HIV infection and gestational diabetes. So how do we want to get this? You see, one, you first find the gestational diabetes among HIV patients. Two, you get gestational diabetes among HIV negative. Three, now compare the two. Okay, so you see how we kept the objective simple. If you don't have space, if you have so many objectives, these three objectives can even be combined into one. To say, just write the third one, to compare the prevalence of this among HIV positive. But as I said, sometimes you may run foul of that rule of being specific, which I say being simple. Okay, so specific objectives, as they are supposed to be what? Building blocks. One is feeding into the other. One, even at PhD level, that's what is expected. One objective is feeding into the other. One is feeding into the other. So they should be seen as building blocks. It should be seen as building blocks. So now we've done this. By the third objective, by objective 3, you have been able to now compare the two of them to know whether it is higher in HIV positive as compared to HIV negative. Then from there, can now go on to some other aspects that you feel is important in your study. Like, so, okay, among the HIV positive people, is there anything that is making the glucose level to be high? That's what this study now wants to address. This is objective. To determine the correlation. You see the word correlation there between what? Viral load and CD4 count, which are what? Continuous variables. And glucose level, which is also continuous. So using correlation here is in order. Okay, so to determine the correlation between viral load and or CD4 count and what glucose level among HIV positive patients. And then the fifth one was to evaluate the effect of other possible determinants such as age, parity, and all the rest among the procedure. Another way of writing this last one is to say, okay, to determine other predictors, other factors that can also influence the relationship between HIV and gestational diabetes. Of course, these are examples. Your study and what you will come up with is expected to be far, far, far away from this one. But these are just showing you examples of how best to work your topic. Last week, I said it and I'm saying it again. If peradventure you want to start writing your proposal and you're having block, you are not making progress. One thing that can encourage you is go and write a title. After writing a title, write research question. After writing research question, write hypothesis. After hypothesis, write the aim of the study. After the aim, write the specific objectives. After that, rest. Then go back and write a background. Based on what we've written, if you check this slide, you see what and what you need. Read the background. From the background, then go on to what? Problem statement. From problem statement to justification. And for me, I always advise people to write the literature review last, because it could be a bit tasking. And if you are writing a segment of the work and it's not moving very fast, sometimes you may get discouraged. But if you've written all these words I've said, in a way you say, wow, I'm almost there. I should give you impetus to be able to write the impetus to be able to finish up what you should finish up. Okay? So I'm just talking practically now. Practically. All right. So let's move on. So as I said, these are just examples, but the basic principle I've stressed it. So you can now use this as example for your own write-up anytime you want. Now, you see where we have been coming, structure by structure. Now we are now at methodology. There is always an issue with whether is it methodology or is it materials and methods, is it methods only? For those issues of definition, please just go by the guideline. Like even this specific objectives that I've listed here, please check the guideline to see what the guideline says. There are some guidelines that may say, no, don't have more than 5 objectives, specific objectives. Some may say, no, don't have more than 4. Some may even say, no, don't have more than 3. So you now have to make sure if it's 3, go for 3. If it's 4, if it's 5, if they didn't mention, then you can list the objective. But please, by the time your objectives are more than 7, by the time they are getting more than 7, they will start getting the audience bored. Except maybe it's a PhD or you are writing for a grant award. For a grant award, maybe randomized control trial, you can have what you call primary objectives and the secondary objectives. Okay? Yeah. But for your research work, keep it simple. Okay? I advise you don't go beyond 4. So for methodology, what I want to say now, I'm sure if you've been following me, you just wonder, say, this guy, are you really serious? Of everything that we go to write, the most important aspect of your work is methodology. I know when I talked about background, I also say it's an important part. When I talked about literature review, all those parts are important, even the objectives. It must be very clear to the audience what you want to study. So make it simple. Don't crowd it, don't crumple it. No, just make it simple. But above all, one area, if it is just one area, you want to make sure it's well done. It must be the methodology. But I advise that you get everything done well. And with this simple interaction we'll add, I think you can get it done well. But if it is just one section you want to get done well, it must be methodology. In exam, methodology takes the highest mark of all the sections. And while doing your defense, it is methodology and result that most of the time you need to defend. The reason is because the method you want to use, there are several methods that can be used to answer the same research question. So when you now use a particular method, you must justify that method is appropriate. Because if you don't use the appropriate method, you can end up with a wrong conclusion. If you don't use the appropriate method, you can end up with wrong conclusion. And that is why methodology is very, very important. Anybody that is flawed, that the methodology is flawed, it is very certain that the person will have to come back. And for anybody, for an assessor to say, no, this study cannot proceed, most of the time, there are issues related to methodology. In 9 out of 10 cases, for anybody to say, no, this study cannot proceed in this current form, they are always related to methodology. So please, if you have not, if maybe you have been in and out with what you want to do, please, even if you didn't get well what you are doing, please, for this aspect, get everything very well. And please note the fact that for your methodology, it's still the same way as we are coming. Don't go outside the box. Don't try to reinvent the wheel. If you are talking about study design, keep it simple. Whatever stuff you are writing, keep it simple. Make it self-explanatory. Under methodology, we should be able to pick your methodology and another person will reproduce that same study. It's not a situation in which we now have to call you to say, how did you do this part? Please don't mince words. Don't hide anything you've done. Everything must be fully explicit when you go to methodology. Okay, so please, it is very, very important. It is very, very important. Now you see all these sections. There are some more, but these are the core ones that I want us to discuss. Core methods, core areas that I want us to discuss under methods. Okay? When you start off your methodology section, the first statement under methodology is your study design. Because your study design grounds everything you want to do. You can't say, oh, this is a case control study, and we got into the work and found out that it was cross-sectional study you did. You can't say, oh, this is a core study, and we got into the work and we found out that no, what you did was not a core study. So whatever you said your study is, you have to go back to say, okay, what is the definition of this study, of this study design? And make sure your work fits into that study design. Please, very important. So the first statement I want to see you state is, what is your study design? State it. Even when you want to write manuscript for publication, under methodology, the first statement is, this was a cross-sectional study, this was a this was a that. Okay, so we pick each of them one by one and discuss. Let's pick them down. So for study design, please don't let us confuse ourselves when we talk about study design. The study design can be based on time. Is it a prospective study or a retrospective study? A prospective study meant that it was after you designed the study that you started collecting the data. While a retrospective study means that data was ready before you designed the study. Maybe I will repeat it again. For a prospective study, you design before data collection. For a retrospective study, what will happen? data was already collected or data was already available before you design your study. However, for most of the colleges, they prefer that you do a prospective study. The reason being that for a prospective study, there are some complications or some demerit of retrospective study that you can get against in a prospective study. One of them is missing data. There may be a particular important variable that you need for you to be able to achieve your objective that may not be available if you are using retrospective data. So the data may not be a particular variable may not be available, or that some of your participants may not have some data. Some data may be missing. And when you start having more than 10% missing data, it may not be appropriate. So please, as we move on, if you have questions, let me know so that I stop. And yes, being an adult education, I'm sorry, but yes, we still have breaks no matter what. Though I know I have so many to do, we started a bit late, but being adult education, I know what it is, so we still have break because I know attention span. But let's move on. Maybe we should have a break for maybe by 3:30. That's 15 minutes now. We have a short break. Say 5 minutes. Hello? Hello, are you with me?
Yes, I will with you.
Okay, thank you. So we've discussed prospective and retrospective. So please don't mix up these things. Prospective is just about time the study was designed in relation to whether data was available or not. That's one. Then another study design is whether you are using what you call primary data collection, which means you are the one that collected data, or secondary data collection, data analysis, or secondary data design, which means that data have been ready. So primary data goes with prospective study, and secondary data goes more with a retrospective study. Okay, so it can be quantitative, which I agree is what most of the colleges will opt for, and that's what we are focusing on now, or qualitative study. We won't talk much about qualitative in this. But if there are occasions that we want to talk about it, no problem. We can always fix if we have people that needed qualitative studies. So we are still on study design because it's very important. And if they flaw you on your study design, the examiner may be angry and may not be ready to pass you. So please take study design very seriously. It is very easy. Another group of study designs are based on whether there is an intervention or there is no intervention. Most of the research that we're likely to be conducting, they are likely to be observational studies. But some of us may still go ahead and do interventional study. Interventional study means that you, as the researcher, you are introducing an external exposure. You are introducing an exposure to one of the groups that you want to study. That makes it an interventional study, and we also call that an experimental study. When I say it is an experimental study, it means what I'm saying is that it is a study. When I say it is an experimental study, what I mean is that it is a study that the researcher have introduced a particular exposure. I will give you an example. If you have two groups of participants that were usually hypertensive, they have been on diuretic, and you now decide to say, no, that if we add a drug B to that diuretic, now if you add diuretic, mute yourself, please mute. Yeah, this is a comparative study. You get there. Please mute yourself. Okay, I didn't get the difference between primary and secondary data. Beautiful. Thank you. Please, I need these feedbacks. It will help me to, because we have a lot to cover. So because of that, I'm a bit, though I'm still trying to be slow, because my aim, as I always say, is I prefer we get it up to one point and everybody is clear than I rush through everything and later on you can't even say, okay, this is exactly, because I want you to be confident about these things and these terminologies. Yes, a primary data means that it is the researcher that designed the study and collected the data for that particular study. That is a primary data. But secondary data meant that a researcher, it may be a researcher, it may be an organization, collected data, sometimes for the purpose of research, sometimes for the purpose of surveillance, sometimes just for routine collection. They've collected that data, the data is there. You as a researcher, you now design your study based on that available data. That is secondary data analysis or secondary data design. So if the data was already available and you now design your study based on the available data, there is secondary data. But if you are the one that is collecting the data based on a particular study design, that is a primary data. And in fact, it can occur so that you decide to conduct a study and you collected the data. After utilizing that data for your study, you may keep it was primary data to you, but this new person that is coming to design that different study based on that. Thank you for that. Okay. Yeah, I think one, I read this person said, please, sir, what is right sequence to go when writing methodology? Study design, study population, inclusion, exclusion, criteria, sample size, determination. Well, I think all this you've stated now is following what I will also, the way I will also go about it. But you can check the guideline, okay? You can check the guideline to confirm how you want it to go, okay? Maoga, good evening, sir. Okay, so All right, so let's move on now. So please, let's keep the chart coming. So for the study design, as we said, we want to say in terms of time, is prospective or retrospective. In terms of intervention, it is experimental or observational. So if it is experimental, if it is experimental, then it means that what? It means that there was an exposure, there was an intervention that you, as a researcher, is introducing to one group and you are comparing with the other. That is what. Hello, yes, please.
Someone has had his hand up for a few minutes now. I don't know if you would like to take his.
Okay, yes, please. You can take, please.
Dr. Omorigbe Isaac.
Thank you very much. Good evening, sir. Good afternoon.
Good evening, my brother. How are you today?
I'm fine. Thank you very much.
Yes.
So please, I just wanted to help me clear some kind of confusion. Sometimes when a study is being done, it's either a descriptive study or a comparative study. I've seen situations where people carry out studies that has multiple groups and they are not compared with any control group, yet they call it a comparative study. I want to be clear about how do we actually now say this study is a comparative study. For example, now, you want to assess the effect of drug abuse among secondary school and tertiary school students. You want to just assess the effect of drug abuse among them, these two groups now, secondary and tertiary. Is this study now, just as I've stated this, sir, is it a comparative study? Because I've seen where sometimes they will be comparing, they will be looking at two different things, and yet they will call it a comparative study. But there's really nothing that they're coming with. So I'm not too clear. If you have groups you are working on, does that make it a comparative study? So I want to be clear on how to actually arrive at a comparative study. Thank you, sir.
Yeah, thank you, Dr. Isaac. I'm always very happy having you because you talk from depth of experience on the field. And we've been together now since 2019, have you?
Yes, sir.
Yes, so thank you very much. You've always been available at our meetings. So yeah, though we still get there, but that's part of me. When you raise questions that I feel we can handle it immediately. When we get there, it will not be like revision. Descriptive and comparative studies, they are usually for when you are dealing with cross-sectional study. They are usually for cross-sectional study. And when you are dealing with a cross-sectional study, maybe when we get there to explain further, you have the exposure and the outcome, and you are measuring the two of them at the same time. If you are measuring the exposure and the outcome at the same time, then it is a cross-sectional study. What do I mean? If you just call a group of, if you just go to a location now, and you get like 100 people, and you call them and ask whether they smoke or not, whether they are currently smoking or not, and now did chest X-ray for all of them to see whether you find people that have lung cancer, for example. So that means lung cancer is your outcome, smoking is your exposure. But both smoking and lung cancer, you are measuring them at the same time. You just collected all of them, 100 of them. And you now say, okay, how many of them smoke? How many of them are not smoking? How many of them had lung cancer? How many of them did not have lung cancer? So when you have that, in which both the exposure and the outcome, you are measuring that at the same time, it is a cross-sectional study. Now, there are two types of cross-sectional study. There is the one we call descriptive cross-sectional study. For descriptive cross-sectional study, what you just did was to just get a group of people and just measure how many of them have this, how many of them have that, how many male, how many female, how many who put on glasses, how many of them, based on the chest X-ray, had lung cancer, how many did not. So when all what you are just doing is descriptive, 40% of my population have lung cancer, 75% of them smoke, 30% of them do this. You know, when you are just doing that without comparing any group, you don't have defined groups you are comparing with one another. That study is a descriptive cross-sectional study. And believe you me, we don't expect you to generate p-value from such a descriptive study. And we don't expect you to generate p-value from that study Sorry, please. So we don't expect it, okay, you to generate hypothesis. No hypothesis is being tested. It's just what? It's just a descriptive cross-sectional study. But please, in this era, nobody reckons with a descriptive study again. Although we still use it to know the prevalence of HIV, prevalence of hepatitis in the community and all the rest, prevalence study. But we don't use it. It's not useful for drawing conclusion. For you to draw conclusion, you will need to compare groups. You need to compare groups. And that one now takes us to this second part of cross-sectional study, which is comparative cross-sectional study. Please note that comparative cross-sectional study is also called analytic cross-sectional study. It has happened before. Okay, then let me not say that at this platform. But just note that when the person say this was an analytic cross-sectional study, what the person is saying is that this was a comparative cross-sectional study. So, Dr. Isaac, that study you were talking about, to the best of my knowledge, is likely to be a comparative cross-sectional study. You have Okada rider on one side, you have motorcycle taxi on the other side. So maybe it's not like you say what?
Taxi drivers. Right?
Yeah, so you have taxi drivers. So you want to find out, maybe you want to find out their knowledge of COVID. Okay, so you compare. So you get the knowledge score for the taxi driver and the knowledge score for the Okada rider, and you now compare. From that comparison, you can now say, oh, the taxi drivers, they have higher knowledge of COVID as compared to what? The Okada riders. So when you are doing that, you'll be able to develop what? Get a p-value to see whether that difference you are seeing is statistically significant. So by the time you are doing that, it becomes a comparative cross-sectional study. It becomes a comparative cross-sectional study. So from your hypothesis, if your hypothesis is that you want to compare this, you want to see whether a particular knowledge, maybe knowledge of COVID, you want to see whether there is an association between knowledge of COVID and the type of driving you do. Then you'll be able to have two or more groups and you compare them. So it becomes a comparative cross-sectional study or comparative or analytical cross-sectional study. So thank you. So we will get there very soon. Thank you. So I just, okay, when we get there, it will be a revision. So back to where we are. So please note that you can either have intervention or no intervention. If there is intervention, if you are the one introducing an exposure, for example, I'm just giving you an example of say, okay, so everybody was on moderatic, you now introduce drug A to one group, and the other group still maintains moderatic. I want to see how the blood pressure will be maybe after 2-3 weeks. When you check the blood pressure of A versus B, when you check the blood pressure of A versus B, and maybe one is now less, you may now say that it is because of that's your intervention. So such a study is called what? Experimental study. In this era, because of the issues of ethics, because of the issues of being able to be sure that your intervention worked, majority of intervention studies, which we call experimental studies, they are actually randomized controlled trial. So that everybody, all the study population, they have equal chance of being in the intervention as compared to the control. But if you have a study which is not a randomized trial, it may not be ethical, because that means you are using some bias in picking your who will be somewhere and who will not. So by the end of the day, when you now say, oh, I found that this worked here, people will say, no. You start picking holes in your intervention. So that is why for people not to pick holes in your experimental study, it's almost like it's norm. Now, if you want to do experimental study, you should go for what? Randomized controlled trial. Now, we say that intervention experimental, then we have observational. Most of what, yes, some people will do experimental study, randomized trial. Since a friend of mine did one recently, in which was comparing analgesia, a particular analgesia in labor, as compared to another analgesia in labor. Okay, and the patients were measuring a pain score, a pain scale. Okay, so want to see. So that one is experimental. You are the one introducing exposure. But I want to tell you that most of the part 2, what people do, they are observational. And that one doesn't make it less important. What most of you do is maybe you collect blood sample, you watch what people have done, and you just follow them up and all that. You see some example of observational studies. So there is one in the middle here, which is what? Quasi-experimental. Quasi-experimental is not common with clinical design, as I said, because there is still an intervention, but there is no randomization. So, and sometimes it may be difficult to confirm. I don't want to, and sometimes there may not even be control. It may just be one arm. From there, you make some deduction. So that's why I call it quasi-experimental. I just discovered myself that we are running a bit late. Let's just focus on and move on. Don't worry. Okay, so let's move on. So we have experimental design and observational. Okay, so that when you want to say, oh, my study is an observational study. So your study can be a prospective study and can be what? Observational study. Okay, but you can't stop like that. You must tell us what type of observational study was it. So for those of us that may do randomized trial, that is, you are the one introducing the exposure. Like those of you in orthopedics, you may decide to say, okay, this group of patients will have external fixation, this one will have internal. And it's not as if you are just picking them randomly. There is it's an experimental study. But when you want to do experimental study and you want to do randomized control trial, please note that your examiner or assessor will be expecting you to state some things like blinding. Blinding is important. You must state what type of blinding you did. The first type of blinding option is open label. Open label means there was no blinding. There are some studies that you can never blind. For example, this one I just said, open visitor and internal visitor. Of course, external and internal. Of course, the patient will know what you are giving him or her. We know whether it was external or internal. Everybody will know. The person that did it will know. So for that, since there is no blinding anywhere, it is called open label. Open label. Those ones, usually we want the best blinding to occur. We want people to aim at triple blind. Okay, to aim at triple blind. But if it's not possible, what do? I will tell us why when we finish just listing them. Why is blinding important? So open label, that means no blinding. Single blind means that you blinded the placebo. Placebo didn't know which group they fall, whether they are in the placebo, which is the control group, or they are in the intervention group. And of course, you have told them ahead of time that look here, we'll give you one of the two drugs. One is the standard, then the other one is what we want to try. It's also good, it won't harm you and everything. You have explained to the, or even say placebo, that means it's not, it's just like water. You have explained to the two of them. So you now randomize and they will take. So in that single blind, where you are, most of the time, even the drug, you must make sure they are similar. I ensure that the same color, the same size, the same everything. You have to speak with the manufacturer so that they will make it the same. Okay. So that's single blind. Double blind means both the participant and the researcher, they are not aware. And then triple blind means the participant, the researcher, and passer, all of them, none of them is aware of which group each one falls into. The reason why blinding is important is because of bias. It's because of bias. For example, we've seen studies in which if you explain to the participants ahead of time that this drug is a trial drug, want to see whether it will work. This one is working. Most of the time, if the patient knows that he is on the one that is trial, even when he's not supposed to complain that there's anything, he will say, since he's on trial, maybe that's why this one is happening. Maybe that's what, So patient will now start coming up with complaint with symptoms that will bias the study based on the group they are. But if they don't know the group they are, they will still behave as normal as they should be. The same thing with the researcher. Why the researcher should be blinded, especially depending that we sometimes measure the outcome. For example, if the study you are conducting is to look for a drug to prevent intrauterine growth restriction, and you now have the researcher that will be measuring their fundal height, or even that will be doing scan for them to know whether there is intrauterine growth restriction or not. It is very more likely that that researcher may have bias in his measurements based on what he knew about what they've taken. But if all of them are coming and the researcher doesn't know who is taking the trial drug and who is taking placebo, we are likely to get accurate results. So that's why we do double blind. And for triple blind, biostatistician will be the one to analyze the data. It is after the person have analyzed the data to group A, group B, and everything, all the result out. That's why we now unblind. And that's okay, group A is actually the trial drug, group B is this. Because sometimes if the biostatistician is aware, he may be afraid or he may be wondering, why is this data like this? This is trying to do some unnecessary over-analysis about it. Even part of this also goes to the laboratory people. The laboratory guys should be blinded, because if they start analyzing and they have a pattern that they know that, DGDM, we suspect that it should be higher. And if they are not seeing that pattern, they will start saying, no, maybe they are not doing the right thing, maybe, But if they are blinded, to the result pattern, to which group they are likely to just do their work honestly and leave the rest. So those are the reasons why blinding is important. There used to be one, even in patient allocation. Even in patient allocation, sometimes it's also important to randomize, important to randomize before you assign them to groups. Okay. So please, if there are questions as to move on, let us know. So that's that for randomization. It's a whole lot of, if we want to spend the whole day on randomized control trial, we can. Several things we can talk about. But please, if you are for randomized control trial, please read well around it and pick some of their literature and register, let me put it that way, to guide you. So now for observational study, we say no intervention. We have cross-sectional study in which we measure both the exposure and the outcome at the same time. Both the exposure and outcome at the same time. So just as I've said, you have smokers, smoking, and lung cancer. If it's that same time that you measure those who smoke and those, you check the X-ray to know who has lung cancer, that is a cross-sectional study. But both the exposure and outcome, you are measuring at the same time. And as we said, these are all what is expected of you. It is a descriptive, just a frequency, percentage, mean. But I've discovered, you read some papers, some people will still say my study is a descriptive study, and they will not say they got p-value. Then you wonder, immediately you can get p-value, it has changed from being a descriptive study to a comparative study or analytic study. Please, let's note that. So as I said, it's not for hypothesis testing, no p-value. But immediately you now divide them into two groups, like this study we are talking about, in which we have those who that are smokers and those who that are not. And now they have those who that are smokers, those who are not. We now have another group of people that have the lung cancer, chest X-ray confirmed lung cancer, and chest X-ray without lung cancer. So with that two groups now, you can do some comparison. Okay, your comparison may be based on the exposure. I say, okay, we have group A, smokers, group B, non-smokers. Then you now start asking, how many group A has lung cancer? How many group B has lung cancer? So by the time you are comparing, you now see that out of 100 smokers, maybe 80 or 50 has lung cancer. Out of non-smokers, maybe 80 has lung cancer. So what that will come up to say is that, it seems that those who that smoke, they have lesser lung cancer cases than those who that don't smoke. So that is where p-value will be generated, because you are now comparing. Okay, you can go on to regression modeling, odd ratio, and odd ratio, because you are comparing. And from there, you can have an hypothesis that you are testing and be able to do a p-value. So that is for cross-sectional study. And I must say that most of us, the study we used to conduct is a comparative cross-sectional study until proven otherwise. It's a comparative cross-sectional study until proven otherwise. But some of us will call it case control, which is wrong. You see the definition of case control in a moment. Okay? It's different from comparative cross-sectional. So you see examples. The first one says a researcher wants to determine the prevalence of hepatitis C among patients attending diabetic clinic in Lagos. Sorry, please, can you see my screen? Hello?
Yes, we can.
Yes, we can see it.
Okay, fine. If you can see my screen, please, this first example, the researcher wants to determine the prevalence of C among patients attending diabetic clinic in Lagos. What type of study design do you think this is?
That is descriptive study. The descriptive Cross-sectional study.
No.
Descriptive
Anybody?
study.
So this is a descriptive, yeah, this is a descriptive cross-sectional study. You don't want to get the prevalence of hepatitis C among a group of people, that's all. You are not comparing them with any group, nothing. So it is a descriptive cross-sectional study. Look at the second one. A researcher wants to compare the prevalence of hepatitis B among patients with diabetes and patients without diabetes. So what would it be?
Comparative cross-sectional.
Yeah, so
It's a
this would
comparative.
be a comparative cross-sectional study.
Comparative.
Comparative cross-sectional study. So here now you recruit diabetic patient and non-diabetic patient, and you check hepatitis B in the two groups. Okay, from there you go to see, oh, this hepatitis B is higher in this group than the other. So it's a comparative cross-sectional study. Okay, comparative cross-sectional study. Then we have the third one, association between smoking and cervical cancer. Here you recruited participants with cervical cancer, and you know those that smoke and those that don't smoke among them. So these two will just be comparative cross-sectional study. Okay? Comparative cross-sectional study. Okay, so the next one we want to get very well is a cohort study. What is a cohort study? The cohort study means that you will go and recruit a group of people that have exposure and another group of people without exposure. And you now start following them up until they will develop the outcome. This for cross-sectional. It is right, and then you measure the exposure and your outcome. Okay? But for cohort study, what you know originally is what is the exposure. What we put them in the group they will belong to is the exposure. One group have exposure, the other group does not have exposure. So this group one that have exposure, you'll be monitoring them until they develop outcome. Group two, you'll be monitoring them until they also develop the outcome of interest. It's the same outcome you are looking for in the two of them. Okay, so for example, if you want to turn the same thing we've talked about into cohort study, what you do is that you have a group of people that smoke, that are smoking. You have another group that are not smoking. Then maybe every year or every two years, you'll be doing chest X-ray for them. The day anyone, either in group one or group two, you diagnose lung cancer, that is the end of the study for that particular individual. Okay, that person have been able to achieve the outcome. So, and that can occur both among those that have exposure and those that do not. So you'll be following them up until they develop the outcome. When they develop the outcome, you say, oh, this person have the outcome. And it's the same outcome for both of them. But what is different is the exposure that they started off with. So when you do that, your study is a cohort study. Your study is a cohort study. Now, so some people also call it follow-up study, but it looks colloquial. I prefer you call it cohort study. Now, there is a subset of cohort study that is all called longitudinal study. For longitudinal study, you also have exposure, no exposure, and you keep following them up. But what you now do is that you'll be collecting outcome or outcome variables or outcome data per visit. For example, you may say, okay, what I want to do is I want to be measuring the lipoprotein. Maybe your study is about exercise and lipid profile level. So you may now start off by saying, okay, let's start off. We have a group that will be exercising. We have another group that will not be exercising. Then every month, you say, okay, they should come. You come to the hospital, you collect blood sample, keep to measure their lipid profile. Month 2, you collect again. Month 3, month 4, you know. So when you do that, such repeated sample collection or outcome collection, then it becomes a longitudinal study. So it is a variant of cohort study. Okay, that's cohort study. So please don't mix them up, get it right away. So for an example here, you recruited a patient that smokes and you recruited a patient that do not smoke. For that cross-sectional study, this wasn't what you did. What you did was that you just went somewhere, you picked all of them that were there. Some eventually found out they were smoking, some you found out they were not smoking. And some you found out had lung cancer, some you found out. So there was no specific follow-up or intention in what you did for them. Okay, that is a cross-sectional study, analytic cross-sectional or comparative cross-sectional study. But for cohort study, the exposure must precede your outcome. You start with the exposure and you monitor them up, follow them up for them to develop the outcome. So here you recruit those that smoke and those that didn't smoke. That's exposure versus no exposure. And you now start monitoring them. And you start monitoring them till they develop a particular cancer of interest over a long time. Okay, so such a study is a cohort study. Like here, another one is that you want to see whether early CA125 level, maybe it can tell us who will develop preeclampsia or not. So what do? In first trimester, you recruited your participants and you collected their blood sample. From the blood sample you collected, some will have high CA125, some will have normal. And you start monitoring them until some in the group of high will develop preeclampsia, some in the group of normal will develop preeclampsia. You can now compare them and do your substance analysis for you to now say, wow, that this early C125 that it was collected can predict who will develop preeclampsia or not. That is a cohort study. Such an analysis is a cohort study. Okay. Now, what people used to confuse is case control study and comparative cross-sectional. See what a case control study is. For a case control study, for cohort study, you started with the exposure. You remember? You started with the exposure and you were following them up until they developed the outcome. But for case control study, you start with the outcome and now look backward in their lifetime to look for what could have led to the outcome. That is a case control study. So case control study by design, they are usually retrospective studies. Because what you do is that you will recruit those people that have the outcome now and those that didn't have the outcome. And you now start asking them questions to know whether they've indulged in things that predispose them to the group they fall in right now that you are seeing them. So the exposure you are measuring is not exposure now, but exposure that occurred in them long ago. If you want to use the same smoking and cancer, for such, what you do is that you go and recruit patients that have cervical cancer or lung cancer. That will be your case. And you recruit patients that did not have lung cancer. You now start them that start asking that 10 years ago, were you smoking? How many months did you smoke for? And all that and all that. And for those who, people that didn't have cervical cancer, you also ask them the same question. That were you smoking? So among that group, you now find out how many smokers were a case, how many smokers were in control. From there, you able to work out the analysis you do. So in essence, what I'm saying is that for case control study, you start with the outcome and you start asking them about their history, life history, to know whether you can pick what led to this outcome. And you compare it in the two groups, both the people that have the outcome, which is the case, and people that they have, which is the control. But this is different from comparative cross-sectional study, in which your exposure is not what happened to them long ago, but what is happening now. What is happening now is what you are measuring. That is the difference between the case control study and comparative cross-sectional. You are measuring your exposure now, but for case control, you are measuring exposure that occurred long ago in them. So is case control study a form of retrospective? Yes, it's bound to be retrospective, because most of the questions you are asking, they are things that have occurred in the past. They are things that have occurred in the past. So what if the exposure is the same, but route of administration is different? For instance, given an intravenous preparation and a topical preparation. Yeah, that's the intervention. The exposure in that instance is the topical versus intravenous. So yes, it can be the same drug, but the route of administration will be different. That is your intervention. And that's the exposure you want, because you believe that maybe the intravenous may work faster than the topical. So that is your exposure. That's exposure. So observing the efficacy, yeah. So it's still an intervention study. Still intervention, because it's you that is determining the exposure, that is determining who will take intravenous versus who will take. But if you are the researcher, you are not the one involved in saying you take this, you don't take this, then it will be it may be observational. If you just go and collect the data of those who that took this and those that will become observational study, because you are the researcher. You were not the one that introduced the exposure. So it depends on the full detail of the research question you want to answer. So, but as I always say, if you have a question and I have not been able to clarify better, based on what I've said, you can redraft the question again for us to answer. So please justify this topic as a core study. Trends and predictors of in-hospital mortality among babies with hypoxic ischemic encephalopathy at a tertiary hospital in Nigeria. Yeah, actually, I want to keep things simple. This topic, that's one of our papers that we published as part of the authors of this paper. This paper is what we called it a retrospective cohort study. That is what we call it. You can have a retrospective cohort study, okay, in which you've already collected the data that you have the exposure at some point, and you now follow them up. Okay, you now want to look backwards to see what happened. So it becomes a retrospective cohort study. Okay, so but I want to keep it simple. That's why I didn't bother going that way. Okay, so this is a case control study, and that's what how we define it. So please note the difference between case control study and comparative cross-sectional study. This is just a schematic thing of what we've been saying since morning. That if you have exposure, you start from exposure or not exposed to what? To the outcome. So this one is for something like this, what do you have? For something like this, you have a core study. Here you have the case and the control. I now look backwards and find their exposure. Okay, and find their exposure, smoker and non-smoker, smoker and non-smoker, among cases and control. So when you are looking backwards in their life course, that becomes a case versus control. Okay, retrospective study, this is a retrospective study in which what? You start from here, I look backwards, that's a retrospective study. A good example is what? Clinical audits. Most of the clinical audits we do, they are retrospective studies. So I think with that, we've discussed the basic study designs that as basic as this is, please don't let anybody confuse you, please. Anytime you need to discuss it. So please let's just have a short 5 minutes break and we'll continue. We still have a lot to do, but I'll be a bit faster. So let's just take a short 5 minutes break, please, and we'll continue. 5 minutes. So this is 4:05. By 4:10, we'll continue. Thank you. Hello? Hello? Can we continue? Hello, can we continue?
Yes, sir. Yes, sir. You can.
Continue, sir.
Okay, thank you. Thank you. Okay, well, one of us say has raised up his hand, please. Dr.
Yes, sir.
Please, you have the floor.
Yes, sir. Thank you very much, sir, for the presentation, sir.
Thank you.
My question is that in a sickle cell patient, whereby we are assessing the oxidative stress markers. However, we want to control with a control group of HbAA, as the normal control. However, you want to check the same parameter in the same patient, that sickle cell patient, during steady state and during crisis. Can we still say, because now it's like you are following up, let's say the same patient presents with in steady state, you took the sample for the patient. However, you want to follow that patient up when the patient is presenting in a vaso-occlusive crisis or whichever crisis. You want to measure the same parameter. However, you already have a normal HbA2 that you are controlled as your control group. Can we still call? Although it looks comparative, can we still say is it a form of longitudinal because we are checking at a particular point in vaso-occlusive, then later in steady state? So what can we call this type of study, sir?
Yeah, when you are like now, in a way, it seems you have two studies in one. One study is between HBSS and HBAA.
Yes, sir.
And that one is a comparative cross-sectional.
Okay, sir.
Okay. Then
yes,
the other one you want to do now is based on what? Based on that exposure.
Yes, sir.
Based on the exposure of
Yes, yes. Yes, sir.
Yes, sir. So you want to just see what will happen before and after crisis. So it's not a classic. It's not a classic core study, but there is what we also call a before and after study. Okay, so it's
yes,
like
sir.
a before and after study. So you have two studies in one.
So how can we qualify that the design now? Can we call it comparative cross-sectional study as well, since it's between the AA and SS? However, the SS is in steady and vaso-occlusive crisis.
No, you see, so you are not defining what exactly you want to do. Because for me, looking at the study, what I thought you want to do was to compare steady state of HBSS with HbA, and then compare steady state HBSS with crisis HBSS.
Yes, sir.
Do you understand me?
Yes,
so that's why I say that you write what you are supposed to write is that your study was a 2-hour study. One is just, if you see my hand now, it's horizontal, so to say.
Okay.
That's the comparative cross-sectional.
Okay, sir.
The second one is now what? It's now moving longitudinally. Which is among HBSS.
Yes, sir.
Yeah. So except if you now say you want to still compare the HbAA with post-crisis, which I don't think will be necessary.
Yes, sir.
You understand?
Yes, sir.
But maybe literature, maybe there may be a good reason, because everything you do There must be justification for it.
Yes, sir.
So it's two-arm, your study is two-arm. One is a comparative cross-sectional study and a longitudinal study, a bracket before and after study.
Okay, sir.
That's what.
Thank you, sir.
Thanks.
I'm grateful, sir. Thank you, sir.
Please, sir, what type of study is this? Evaluation of serum vitamin D status among HIV positive, HIV negative children, age 0 to 14. So, who will help us with this? Anybody? Anybody? Oh, yeah, now, if you are the assessor, what study will you call this? You can't see it. I think you are seeing the chat box. Please check the chat box. Evaluation of serum vitamin D status among HIV positive and HIV negative children, age 0 to 14 years. What type of study design is this? Oh, yeah, now, so that we'll go. Nobody want to bear the cat. Okay.
So, hello, sir.
Yes, sir.
I think it's a descriptive cross-sectional study, sir.
Descriptive cross-sectional. Any other idea?
I think it's comparative cross-sectional, sir.
Comparative cross-sectional. Any other idea? Any other idea? Yeah, I think I will go with comparative cross-sectional, because here, what the research I want to do is to compare vitamin D level among HIV and compare it with what? Among HIV negative. So at the end of the day, it will be coming up with a comparative cross-sectional study. So I'm happy that we all got it right, which shows that what we've been doing is fine. But as I said, some people will want to call this a case control study. For this to be a case control study, you have HIV patients and non-HIV patients, and you now go back in their history, maybe like 10 years ago, if they've collected their blood sample, to go and check their vitamin D 10 years ago. That's what you do. For it to be a case control study. Okay, for it to be a case control study. So that's the way. So fine, I'm happy you got it right. Now for site of the study. So finish with study design, site of the
Excuse
study.
me, sir, someone has his hands up.
Okay, so please.
Dr. Omaribe.
Thank you very much. Thank you very much, man. Thank you, sir.
Yes,
sir, please, I want to be clear with this cohort study. From what you explained to us, sir, it was clear that there will be an exposure and an exposure group and a non-exposure group, and we follow it for some time to find out the outcome. So what about some studies that you don't have the non-exposure group? What just binding them may just be one variable, like, for example, now for COVID-19, patients that were admitted in the hospital because they have COVID-19. You want to find out the reason why they died, those that died, why they died. That is the predators of mortality among those people that had COVID-19. You want to find them out. And the study design is a retrospective cohort study. It can also be a prospective cohort study. I want to find out, in this particular study, there is no group that is being compared, and yet it is called a cohort study. Just like your study I put up earlier on, sir, there was no other group that was being compared. So I want to be clear on how do we actually now see a study that does not have other group Yet we say it is a cohort study, either a prospective or a retrospective. Thank you, sir.
Yeah, thank you for the very difficult question. Yes, what we just presented is the, how will I put it now, is the norm. Then we can now start having the exception to the rules. Yes, you can have a group of patients that you followed up. Cohort just means you have an exposure and you follow them up. So sometimes you have a comparative group, sometimes you may not, but most of the time there is. So without a comparative group, it's still a cohort study. And the type of analysis you have to do for such study is Kaplan-Meier or Cox proportional. And you can do Kaplan-Meier or Cox proportional even without a comparative group that didn't have exposure. You can. Okay? So it is possible to have a cohort group that didn't have that have only all of them have exposure. All of them have exposure, and then part of what you can do is you can now start talking about survival rate, time. Maybe you want to see time to death. You want to see maybe 1 year, how many of them survive beyond 1 year, how many of them survive beyond 2 years, and all that. So it's from that type of calculation that you'll be able to have those that you compare with. You do what you call right sense. Sorry. So thank you very much. Yes, it is possible, based on those examples you've given, for you to have a core study in which all of them are in the exposure group. Are we okay? Okay.
Thank you, sir.
So thanks for that question. I don't want to go into those things because I don't want to confuse people. All right. So site of the study. You must be detailed about the site of your study. So you say, okay, this study is going to be conducted at so and so. If it is in the institution, you state the institution, you state whether it is a tertiary institution or secondary institution. You state the institution in context. Is it the only tertiary institution in that state? Is it 1 out of 5 tertiary institutions? If it's a secondary institution, is it 1 out of, is it a private institution? Is it a government institution? You know, if it's a multi-center study, you state it and state those people that will be involved, and those centers that will be involved, you know. But if it is community-based, in which is a whole local government you're covering, you state it, you're covering also as a local government, which is 1 local government out of 14 local government in the particular state, whatever. So you must write and situate your site of the study in context. For those of us that will be doing clinical work in the lab or in the hospitals, please, you need to also put here what is the expertise of the laboratory person, the laboratory facility you have in that place. You need to state the number of patients, average number of patients maybe per month or per year you see. The reason why you need to state that is you want to be sure that your study is feasible. If you see 30 women per month, and you now say your sample size is 1,000, by the time you divide 1,000 by 30, you see the number of months it will take you to recruit patients. And for a part 2, we know it's supposed to be for how long. So all those things, you must justify everything. Everything must be in line. Okay? You can even still go on for some cases that are maybe interventional cases to tell us what is the standard of care in the hospital. If maybe you now want to introduce something, you should tell us the standard of care in the hospital. And I remember we did a study of vitamin D. If you are doing a study of vitamin D, in which you know that wearing of clothes, whether you stay in the sun, and all those things will affect the level of vitamin D among your participants. You need to tell us. You need to situate it and tell us the latitude and longitude of that location and tell us the temperature pattern of that location. Okay? So those things need to come and you must be as explicit as possible. And sometimes people copy and paste, which may be dangerous. Now I've reviewed papers, I've reviewed proposals from Lagos. I've reviewed from outside Lagos or even from Nnewi, for example. The person that was writing from Nnewi made us to believe that, look, Nnewi is a commercial city. They sell, they have industries, they have this, they have that. But people writing from Lagos may not write like that. So you should try to make sure what you are writing is specific to that location. And that institution, please, how many beds do they have? So all those things, please be as detailed as possible in stating the site of the study. You see, the idea about all this is reduce the number of corrections the person will make. Okay? If the person is making fewer corrections, you are likely to get your book back on time. So that is why every segment, you should write it to the best of your ability. All right. Now we move over to target population. For target population and study population, when we talk about the target population, oh, this is supposed to be, okay, the first one, I just want us to note that we are supposed to state the proposed duration of the study. If your study will be from January to March, state it. If from January to June, state it in your, and be specific. From 1st January to 30th June, okay? Because those are what the assessor will use to calculate to know whether the study is feasible or not. So please always state the proposed duration. And when you finish writing, when you are writing your dissertation, you now change the proposed duration to the actual time taken for you to conduct the study. You have to state it somewhere in your work. So now people confuse target population and study population. They are two different things. Whenever you want to conduct a study, you want your inference, you want your conclusion to be about a particular set of people. And that is why I always tell people not to be over-ambitious. Don't say this my study should be about Nigeria, Nigerian women or Nigerian men. Even a state, don't say this study should be about a state. But if you say it should be about a state, then that means everybody in that state must have equal chance. The way you design a study, everybody in that state must have equal chance of being recruited to your study. Okay? So keep it simple. If you know you don't have the facility, you can restrict your study to a particular institution. So your target population is like what we call the pool. It's like everyone that will be available or those people that you want your study to, in fact, the conclusion to be about. That is your target population. It is from that target population, that pool, that you now get some participants that you will now actually study. Maybe you give them a questionnaire, you collect blood from them and all that. So those ones you now actually studied, they are the study population. But the importance of target population and study population is that the study population is the population that you will conduct your analysis on. But when your conclusion will not be about that study population, but about the target population. Your conclusion will be about the target population, your your study population will be this, your analysis, statistical analysis will be about your study population, but your target population will be the outcome, will be about your conclusion. For example, if somebody says you want to look at the outcome of appendicitis patients in LUT, this means that every patient that had appendicitis and managed in LUT have equal chance of being recruited for this study. So what we want to talk about now is that in LUT, our patients after appendicitis go home after 3 days. Our patients, most of them die, or few die after appendicitis. Or this is the wound infection rate among our patients. Things like that. That is what you want to achieve. But you've already capped it to LUT, so that every patient that comes to LUT have equal chance of being in their study. But if you say outcome appendicitis patient in Lagos, that means everybody, whether in TBA, whether anywhere in PSC, anywhere the patient had the appendicitis, is part of your study, is part of your target population. And they all have equal chance of being recruited. That is why it is always dangerous for you must watch your the location you put in your title. Okay, don't make it loose. Be specific, because people can take you up on that for us to know whether your conclusion can actually be generalized to that, the whole target population. Okay, so in that case, all appendicitis patients in LUT will be our target population. So the study population will now be out of this target population. Those ones that eventually were recruited for the study will be the study population. But when you are now discussing, your discussion will be saying that, this is what happens in LUT. But when you are analyzing, you'll be analyzing participants that participated in your study. What is there's one. There's one slide that I've missed now. It's painful. It's painful. Well, let me look for it quickly so that I'll just use that. It's a good. Okay, let's move on because of time. Okay, so that's that about target population and study population. Yeah, we'll come to eligibility criteria. Eligibility criteria is just stating those people that will be included in the study and those that will be excluded. Here, the key thing I just want us to note is when we talk about the exclusion, most people will list correctly the inclusion criteria. But where issues come, study area and area of study. This is issue when you are dealing with what is it called? These are things we don't like in when you are writing. There is the question: what is the difference between study area and area of study? I will advise you avoid the second word, area of study. It's better you just say study area. Because area of study, yes, it may mean study area. It may mean area of focus. Where are you focusing on? So when you are writing, you must avoid terms or terminologies that may mean more than one thing in the mind of the audience. So I would say we should stick with study area. And just on baseline looks like they are the same, but area of study could also mean some other things apart from study area. So I would suggest you stick to study area. So most of us will list the inclusion criteria, but make it brief. Brief inclusion criteria. You just say, okay, patient that come for so and so within age this and this, or maybe with singleton gestation for those of us in ORG. Exclusion criteria is where they used to catch people. What people now do is when they've listed the inclusion criteria, when they now get to exclusion criteria, they just start listing the opposite, which is wrong. Exclusion criteria is not the opposite of inclusion criteria. Exclusion criteria means that after you've recruited, after you've had your inclusion criteria, you still want to exclude some people from those people in the inclusion criteria. For example, if you've said that the age is between 4 and 14 years, if you now come to exclusion and say exclusion criteria, anybody older than 14 years, no, that's not correct. Because you've already told us that your inclusion is 4 to 14. So you don't need to now start telling us those that were excluded were those people above 15. No. What we now mean is that between that 4 to 14, there could still be some people with confounding variables. For example, we're dealing with vitamin D and HIV status. Now, we want to know whether it's HIV that is causing it. You may not say, okay, I've recruited babies between 4 and 14 years. Now, what I want to do is babies that are on maybe steroids, if I know that steroid will affect vitamin D, then I want to exclude them further. Babies on some drugs that I know can affect vitamin D metabolism, I want to. Even babies that are even on multivitamins or vitamin D, because you want the natural relationship, you don't want the one that somebody that have taken, So that is what exclusion criteria means. You have to think back that among those people that have included, who and who should I exclude because of confounding variables or bias? That is what exclusion criteria is. You've already stated that your exclusion, your stuff is singleton pregnancy. You now come to exclusion criteria, say twin gestation. It's wrong. Or you say you are recruiting people in the first trimester. You now come to exclusion criteria, you say, how we got that? So that's the key thing I want to stress with eligibility criteria. Now, sample size and sampling technique. This is where that stuff I want to show you matter. Maybe I will look for it here now. I'm sorry for taking our time. I think it's better we're a bit slow this way than we are fast and we didn't cover everything. We didn't get everything we need to get.
A hand is raised.
Okay, please, the person can continue while I look for what I want to look for. Yes, you can speak, please. The hand that is raised can speak, please. Amoregbe, Dr. Isaac, please speak.
Sorry, sir. I'm sure it's the previous one, sir. Sorry, sir.
Oh, okay.
Sorry, sir.
So we want to discuss sampling technique and sample size. Okay. Okay, can we all see this?
Yes, sir.
Okay, fine. We can all see this, eh? Beautiful. So I always like explaining the reason why sampling and sample size is very important. So that when people disturb you on it, you yourself, you know that mainly that area is flawed. You know that area is flawed, that your conclusions may be a suspect. So as I just said about target population, you have a target. I hope you are seeing my cursor. Can you see my cursor?
No, sir.
No, sir.
I mean this cursor, this my cursor moving on this. Can you see it? You can't,
No.
eh?
No.
Oh, okay, sorry. Okay, no
No, we
problem.
can see, sir.
Okay, but can you see this population parameter?
No, sir.
Where I wrote population.
No, sir.
Huh?
Maybe you share the slide, sir.
No, sir.
Oh, I've not shared.
No, sir.
The slide is not open, sir.
Ah. But showing already shared. Okay. Okay. How about this? Can I see it now?
Yes, sir. Very okay.
Yes, sir.
Yes,
Because
sir.
initial statistics.
Okay, beautiful. And can you see my cursor?
Yes.
Okay, beautiful. Thank you. Yeah. Thank you for the feedback. What is happening? Okay, so based on this, can you still see it? I want to confirm because I don't know what's happening. Can you still see these influential statistics?
Yes, we can.
Okay, fine. So here we have the population, which is the parameter. So we have the population. This population written here is the target population. Everything about your study, you want it to be about this target population. Now it is very difficult because of issues of funding, feasibility, time, and all the rest. For you to sample, for you to use everybody in this population for your study. So see, it is not possible for you to use everybody in this population for your study. What researchers do is to get a sample of this population. Can you see how my cursor moves? Okay. So what most researchers will do is to get a sample of the population. But this sample you are getting must be representative of the population. For the sample to be a representative of the population, that sample must have been selected in such a way that everybody in this population have equal chance of being selected as a sample. And for everybody in this population to have equal chance of being selected as a sample, there are two things that must be done. And they are sampling, random sampling, and sample size calculation. You must calculate enough sample size that will be representative of this target population. And you must sample this population in a way that everybody here has equal chance of being part of the sample. For everybody here to be part of the sample, to have equal chance of being part of the sample, your sampling technique must be a random sampling technique. Must be a random sampling technique. And your sample size too, you must calculate it in the way it should be calculated. So it is when you now get this sample, which is your study population, you investigate them, collect sample blood from them and not the rest. And after that, you now subject them to inferential statistics. And these inferential statistics are the statistics that can give you p-value, can give you confidence interval and not the rest. So when you now get these inferential statistics, your results, you can now infer it about the population. So that is why if your sampling technique is wrong or your sample size is not adequate, what will happen is that you've broken this circle. That means the sample is not representative of the population. And even when you apply inferential statistics to it, whatever you are getting, we cannot say is a conclusion about the target population. So you see that two very critical areas that you must do in your research work is sampling and sample size. Then when you get here, we'll ask you all the various things. How did you ask your questions? How do you collect your sample? The laboratory tests and everything. When you get all your results ready based on this sample, then another critical point is this type of statistic you use. You must use the appropriate statistics. Though today is not for statistics, but I just want you to know, you must use appropriate statistics before you can now infer about the population. So any question about this sample, I always like stressing it so that it will, whatever it is, you know that it is very important. Every aspect of your research work journey is very important. Sampling, sample size, when you get here, that sample, everything you are doing there, we inflect the influential statistics you do. And it will not affect your work. All right.
Hello, sir. Hello, sir.
Yes,
I don't know if I can ask this question, sir.
I'm with you.
Thank you, sir, for the wonderful and beautiful presentation.
Yes, please go ahead.
And lucid, more importantly.
Yes.
I just want to find out concerning the sample size, does the control follow the same pattern? What you just explained to us now.
Yes, you must pick both the case and the control. But please, let's correct ourselves now. You are not likely, anyway, I don't know what your study is. You are not likely to do a case control study. You are likely to do a what? A comparative cross-sectional study.
No, well, yes, I know. I'm just about the case when you are in comparative, yes.
Yes.
The control that yes, sir.
Comparative group 2 must follow the same pattern. Yes, you are right.
Okay, sir. That is what I mean, sir. Thank you, sir.
Yes, thank you.
God bless.
So yes, very good. I'm happy that you are following me. So that is why sample size is very important. And sampling technique is very important. Okay? And people can have issues based on this. And you cannot blame the examiner based on that because your conclusion is wrong if you've not taken care of this foundation. So I will open our eyes to some ideas, but please, you need to consult a statistician whenever you want to calculate sample size or sample technique. But even if you are consulting with a statistician, I would approach that you should have an idea of what the person wants to do. So if the person is not doing the appropriately, you will know. If the person is doing the appropriately, you will know. You understand? So you have an informed view about it. So for it to calculate sample size, please note that it is a very important, yes, I've said that, and there are standard formula for different type of sample size you want to the study design. So sometimes if you state your study design, I will go and check your sample size calculation. You cannot say your work is a comparative cross-sectional study, and at the end of the day, you are using the sample size for prevalence study. I will not agree. Okay, which you will see very soon. So if your study is a prevalence study, fine, you use the sample size formula for prevalence study. If your sample size, if your study is about comparison, which can be either mean or proportion. Mean means if you are comparing continuous variables. Proportion means if you are comparing categorical variables. Okay? If you are comparing continuous variable, that's comparison of mean. If you are comparing categorical variable, that's comparison of proportion. So you can start thinking about your outcome. What is your outcome comparing? Okay? If I, for example, if I'm comparing hemoglobin level among two groups of people, that is comparison of mean. But if I'm comparing the prevalence of anemia among two groups of people, that is what? Comparison of proportion. The same thing if I'm measuring the systolic blood pressure among two groups of people, that's comparison of mean. But if I'm comparing whether so a group of people, how many of them are hypertensive or not, that is a comparison of proportion. So please note that. So these are some basic study designs that have their own sample size that you should know. Comparison of mean, comparison of proportion, randomized control trial, diagnostic test, like validity study. If you are doing a study that have to do with sensitivity, specificity, and all the rest, that's diagnostic study. So your sample size should be along diagnostic study. Of late now, I think I have two very nice resource material that I can share with you guys to understand. They are very, at least to a reasonable extent, they are very self-explanatory. But these are, we're just exposing you to it. Before you say you want to calculate sample size, you must ask yourself, what is my study design? So when you've done that, when you've been able to know the study design, then the next is, what power do you want to use? Are you talking about 80%? Usually we use 80%, but for some studies like randomized control trial, maybe drug studies, we go as high as 90%, 95% power. Okay, then confidence interval 2, you want to know the confidence interval you want to use. Most of the time we use 95% confidence interval. Remember when I was saying two-tailed test, whether it's going to be a two-tailed test or one-tail. So these are considerations you put in, and the formula will ask you so that you have FMCOG table you will use to put them in. And you can also use a software to also do this. The last statement I made there, well, if you know you do a regression model in your work, you should have 10 times the number of observations and 10 times the number of variables you want to put in the model. If you want to put 10 variables in the model, then your minimum sample size should be 100. If you want to put 8 variables in the model, variables means age, gender, place of residence, like that. If there are only 8, then your minimum sample size should be 80. So even if you have calculated based on other things, that's less than 80, you can up it to 80, and you say you are increasing the sample size because of regression analysis. So Yeah, so these are, I will share with you. This is one of those very nice article on how to calculate sample size. Okay. And this is another one. This is by Nigerian author in the Nigerian Journal of Postgraduate Studies. They've done good job. Okay. Although if we don't have this type of exposure that we are having, it's difficult following them. But with this exposure, you just know where to go to pick what you want. So these two, they are very good. Now I want to just quickly show you this material I prepared one time ago about sample size. I'll just go through it quickly and then share with you. So as we said, for sample size calculation, what you do is based on the type of study. If it's a prevalence study you are dealing with, for example, you want to study the prevalence of diabetes in a particular population. As we said the other time, prevalence of hepatitis B, prevalence of hepatitis C, prevalence of HIV among a group of people. The formula is just to say what? N equals Z squared PQ over D squared. That's for prevalence study. And you see what Z is. Z is a normal standard deviator at confidence of this. And it is usually 1.96 for 95% confidence interval. If you don't want to use 95% confidence interval, then you have to go, you can even Google it. You have to go to the FMCOG table or tables to see the corresponding value of Z for any other confidence interval. Okay, but most people will use 95. So you know your Z already. Prevalence. So P is prevalence. To get the prevalence rate, what you have to do is you check previous literature to know what prevalence they've calculated, they've got for diabetes in a similar population. Some people used to make mistake with this. For example, you are dealing with prevalence of diabetes among maybe HIV patients. You now go and start getting prevalence of diabetes in maybe hypertensive patients. It must be prevalence of diabetes in HIV patients in the literature that you use. So your research question must be very close. The prevalence you use must be very close to the one. So you get, and it is safer for you to get the prevalence that have been done in your environment or in the environment or somewhere that have similar population as your target population. Then D is precision or margin of error. Usually we allow 5% margin of error. Then you substitute into the formula and get your prevalence value. Now, when you get the prevalence value, usually we add what you call attrition rate. Attrition rate means that you say that after you recruited these patients, may have issues. Maybe the blood sample you collected for some, they have problems, missing numbers, missing values on their age or on their weight. You know, there will be some people that have such problems. So for that, you add what you call attrition rate. Some, it may be what you call non-response rate. You send questionnaires out and some will not respond. So, and the attrition rate will depend on the study design. For a cross-sectional study in which you are getting everybody at the same time, okay, 10% may be appropriate. But if it's a cohort study, that you are monitoring the patients over time, some may be lost to follow up. So for that, you may need to increase the attrition rate. But if it's a cross-sectional study and you are putting the attrition rate as 20%, the person may query you, how can you say you have a cross-sectional study and the attrition rate will be as high as 20%? That's too much. Okay, that means you propose in your heart that you don't want to do a good study. If not, you are collecting all your samples at the same time. So why must it be that samples that you are collecting like that, we have so much a high attrition rate. And if it's a core study and you are now using 10% attrition rate, it will just smile, because it means you don't know the implication that core study, most patients may be lost to follow up. Some may go, the day you say you should come, it just tell you that it's not coming again for this study. Okay? Whereas you guys have built rapport before. So that's why, so please, the attrition rate is not just a blank figure. You have an idea. So generally speaking, for cross-sectional study, we use 10%. For core study, we use like 20%, 15 to 20%. So whatever you calculated, you now add it. Now, one other thing I want you to notice is that when you are rounding up 299.3, if you must round up 299.3, it should be 299, I believe. Do you agree with me? 299.3.3 approximately should be 299. Sample size calculation. Immediately you have a point something, you must round that one up to 1. So 299.3 is the same thing as 300 participants. Okay? So it is better to have more than to have less. Because if you use 299, that's still less than the minimum sample size. Because the minimum sample size is 299.3. So 299 is less than the minimum sample size, but 300 is more than the sample size, minimum sample size, so it's fine. So that's why you round up rather than rounding down. Very important. As simple as this may be, some examiners will pick it. Okay, so please know, if you send this across finite and all that, when you read it, you will understand. Because of time, let's just quickly go. So we have comparative study. You have a study that says that the aim of the study was to compare maternal serum nitrate level in women with diabetes in pregnancy and women with normal pregnancy. So your study comparison.
I mean, I will come and meet you there.
Your study, please mute yourself. So wherein there was not been any study carried out in that study, how do we determine P? Okay, I stated it there. You can do what you call a pilot study. Okay, the rule of thumb is you can pick 20 participants. That's for our level, small, but if it's for a big project, there are other things you can do. You can calculate the sample size, start working. Maybe when you are halfway, you now check the rates in those people, and from there, you now use it to calculate the actual sample size. But the usual thing we advise people to do is to do a pilot study. If you really check, you've not seen. So you can just get like 20 people of your target population. If it's a prevalence of hepatitis, check their prevalence among the 20 and use that prevalence. But please note that those people you use for pilot, you will not use them, they will not be part of the study again. Immediately you finish with them, they are discarded when you now want to recruit for your study. So please, anytime you say you've done the pilot study, we are looking out for you to say that those people that were recruited for pilot study were not eventually part of the main study. So if you read up that part is there, I stated that. Yes, your the sample size, the prevalence you use very recent sample size, use the population you are dealing with should be very close, that you are using should be very close to the one you are dealing with. Okay, very close. All right. So now we have this aim of the maternal serum nitrate levels in women with diabetes in pregnancy and women with normal pregnancy. So because the outcome of nature is nitrites, which is a continuous variable, what we use is comparison of mean. So this will be the formula. So this is the formula for calculating comparison of mean. And what is the standard deviation? The standard deviation will be for the normal group, Sometimes you can use it for the normal group. Sometimes it can be the mean of the two. Some will say, okay, use it as the mean of the two. Some will say, no, just use it for the study, the normal group. Then Z alpha is when you have a confidence interval of what? 95%, and Z beta is power. So you just substitute all these values, 0.842, they are constants if you are using 95% and 80%. But if you are using another one, then you have to go and check the table to know what Z alpha and Z beta is. I just substitute to the formula. So the key thing, as I'm saying, is for you to know the type of study design. So it's the study design that will determine what you do. Okay, then this one, if the outcome is okay, this is under continuous variable. Okay, so it's still the same thing said in another way. So this D here is actually the same thing as what? Mean of one group minus mean of the second group. That's, you get it from the literature and square. Okay, so you can just go and try it out for yourself. The proportion, that's the formula again. The key thing is for you to just, this formula you can always put it there. The key thing is to know when and where. Okay, so they follow the same format. So I will share this alongside, so the organizers will find a way of sharing it with those who are interested. Okay, but I'm just exposing you to it for you to know that it's not really something of a serious, terrible, big deal. Okay, that you can't cope with. But I will still suggest that you see a certified statistician that you guys discuss together. So now let's go back to our slides on Gobi and see how we can quickly run through. We are now short of this. So discuss, so for sampling technique, okay, the key thing is that it can be probabilistic or non-probabilistic. Probabilistic, another word for probabilistic here is random sampling and non-random sampling. Okay, reason for sampling, I think I can skip this. What are probabilistic sampling? You can read about this. But the key thing, what we want to get there is that is random selection. And that is what is preferred, because all the statistical analysis that you'll be using, they are based on random sampling. Okay, so it is only when it's not possible for us to do probabilistic sampling that we'll go ahead and do non-probabilistic. The simplest non-probabilistic that most of us do is what we call consecutive recruitment. Consecutive recruitment is non-random, so it is non-probabilistic. So it is a limitation of most clinical studies, but we don't have choice because of sample size, because the patients are not many. So it's not easy for us to do a random sampling. Okay, so but please have it at the back of your mind that consecutive sampling is non-probabilistic, it's non-random. So these are types of probabilistic sampling. This sampling alone is a full lecture. It's a full lecture, so but I'm just letting us, exposing us to them. So please, when you see non-probabilistic, for us, let me just explain one or two of them. Snowball means that it's used more for patients like patients that have sex with males, because of the issues in the community about it, about stigma and all the rest. It's not easy for you to see them around. So when you get one of them, you build rapport with the person, you build interest, and the person trusts you. So it's that person that will go and bring another one. So you'd have two. Those two will go and bring two more. So before you know it, you now have many. So when you are doing that type of sampling technique is called snowball. Okay, the other one I want to mention is convenience. See, there are different types of convenience sampling. So when people write and say they use convenience sampling, I just so I would prefer you say you use consecutive sampling technique than saying convenience sampling. Because convenience sampling is not exactly the same. Consecutive sampling is a type of convenience sampling. So please, it's either you write convenience sampling, which is consecutive sampling technique, or you just say consecutive sampling and move on. Nobody will query you. But if you say convenience sampling for me, I will ask you what type of convenience sampling I did. So please, let's note that. So for the study design, study procedure, please, you need to be detailed. Okay, that each patient will be approached, or after being approached, those ones that consented, you will fill the form, you will fill consent form, you explain the result to them, then they will fill consent form, like that, and you must explain who is doing what. There was some occasion that we don't want you as a researcher to even recruit the patient because we believe that there is a power play. If you are the doctor seeing them, they will willy-nilly just have to accept. Okay? So in such situation, you may have to ask the nurse to do the recruitment. Okay? Well, after being recruited and they've agreed, then you can now speak with them and then enter whatever data. You must tell us who will interview them, what type of questionnaire are you using. Is it structured questionnaire, which means all of them is yes, no, two, figures and all that, or semi-structured, which means that there are some unstructured questions. But if you are dealing with a quantitative study, it is safer to use structured questions because it will be easily analyzable with most of the statistical tools. Okay, so those are the things. Then I want us to know the difference between data extraction tool. Usually we use it for secondary data analysis. The data are available. You just use your own tool to extract what you need. Questionnaire is what you use to get information during interview from your participants. Proforma is the same thing as questionnaire plus lab results. So if you know that in the same document you have lab result, then it becomes a questionnaire, it becomes a proforma. So I use the appropriate register. Okay, so who is administering the questionnaire? Is it self-administered or interview administered? And you must know the bias that will occur from any of these. If it's self-administered, the person may not understand some questions and will just pick whatever he likes and move on. That's the issue with self-administered. But interview administered, the person that is interviewing them understands and is asking. But if you are dealing with questions that are very sensitive, that are intrusive, the responses may not be as good as self-administered, anonymous self-administered. Okay, so there is what we call social disability. Social disability may come in when you are dealing with interviewer administered. Even if you are saying, do you smoke? You know that generally we don't want pregnant women to smoke. We say no, so that you won't feel that, oh, you are the one that is few ones that is smoke, things like that. But if it is self-administered anonymous, the person may say the truth. So you must be able to know the issues. Each of them have their own pro and con. Then the laboratory procedures, please, you need to sit down with the laboratory scientists to tell you step by step, including quality controls, everything that need to be done during the laboratory processes, and you state them in your work as detailed as you should. Now, during the recruitment exercise, please note that confounding variables. In the recruitment exercise, please note that confounding variables may occur. For example, if you are dealing with HIV positive and HIV negative and glucose intolerance, for example, you want to say is the HIV that is causing the high glucose. But generally, obesity, weight may also affect glucose. So if you now have that more HIV patients are obese than HIV negative, it may be the obesity that is higher in HIV positive that led to the high glucose and not necessarily the HIV virus. And you will not know. So those are what we call confounding variables, but I won't bother myself defining it now. But the key issue about all those type of variables, so when you read literature, you'll be able to say, okay, so these two can also affect this my results. So because of that, I must handle it so that at the end of my work, nobody will say, is it not because the weight is higher here than here? That's why you got what you got. So it's not because of the HIV. So you won't want anybody to be able to come up with that. So you have a list of what are the confounding variables, okay? And what confounding variables are variables that can affect, that can also cause the outcome, but also have an association with the explanatory variable and will not be in the causal pathway, but I don't want to bother you with that. But just have an idea of what those things. Now, how do you handle confounding variables? We handle confounding variables, one at the design stage and at the analysis stage. If you want to handle confounding variables at the design stage, what you do for, sorry, I saw this. Thank you, sir, so much, sir. Is it advisable to calculate sample size for a population study? Well, the population study depends on what you mean. Is it population-based study? Or if it's a population-based study, if you can recruit everybody in the population that have the attributes you are looking for that are a target population, fine, you can go ahead. But if it is not possible, which most of the time may not be possible, you still need to sample. You still need to sample using different technique, can be stratified sampling technique and not just. And if you are going to sample, you must now know how many out of that total you need for you to still be able to make a conclusion of everybody. Okay. So I saw one more here. So the continual variables, 2 or more, e.g. serum, zinc, and copper, magnesium. How do we know one to use as the mean value from the variable? Wow, this is a wonderful question. What you are expected to do, the standard thing you should do is you go for zinc to calculate the sample size, use copper to calculate the sample size, use magnesium to calculate the sample size, and you now go for the one with the highest sample size out of the 3 of them. That's what you use. I hope you got me clear. Okay, you use zinc to calculate separately, copper to calculate separately, magnesium to calculate separately, and after that, you now pick the one that have the highest value. So if you want to show off, what I will do is that, if it's my proposal, what I will do is I will show the one that have the highest value in my proposal, and the other 2, I will show them in the appendix. I said I also calculated for this and this, and they are in appendix this and this, but they are lower than this. That's why I chose this. Okay, so that's that. But one way of getting avoiding issues like this is, if maybe it's a trial, you may have primary objective and secondary objective. So if maybe zinc is the primary objective, if zinc is the primary objective and copper and magnesium are secondary, then you don't bother about the secondary, you just calculate for primary. But for most part 2 work, I would suggest you can handle the as if all of them are primary, and then you calculate for all of them and pick the one with the larger sample size. So I want to see if there are any other one before we move on, because those interludes too, they help for us to So yeah, we've done this. Thank you so much. Is it available to calculate some? Yeah, we've done this. Sorry to take us back. I did not, what? I did not get your explanation of the difference between target population and study population. Target population just means the whole population that you want your study inference or conclusion to be about. And study population are the actual people that you collected their sample, you give questionnaire to and everything. Because the people you collected their sample and you gave, they are just a sample of the population you want your study to be about. And your target population, everybody in your target population have equal chance of being selected as your study population. Okay, so if you read the slide, you get it for that explanation. Okay. So as I was saying, for you to prevent the problems of confounding variables, you can handle it at the point of study design, and you can handle it at the point of statistical analysis. If you want to handle it at the point of study design, what you use is what you call matching. You can do matching at that point. And how do you do matching? What you do is that you pick, you know those variables that are confounding variables and ensure that they are equal across the two groups. For example, if age, for those of us who are age, parity, and BMI, if you know that these three things can affect glucose metabolism, and you know that your outcome here is glucose metabolism, what you can do is you make sure that when you get somebody that has HIV that is 30 years old and parity is maybe 1, you now go to HIV negative. You get HIV negative that is also of the same age of 30 and also of parity of 1. So that's how you be doing it. That's what matching is. So you can match on age, parity, BMI, and all the rest. But if you've conducted some basic research before, you discover that it is very difficult and time wasting for you to match variables like that. Because even when you get to HIV negative, I now saw HIV negative that is age 30 or parity of 5. The person can't match with that positive. Okay, so such issues used to come up. So that is why I always advise people that please, if you match, maybe you just match on one variable. By the time you are matching on more than 1, 2, some will even say they match on 3. I know it's practically impossible. So if your assessor raised the issue that why are you not matching on other variables of interest? Tell the assessor or politely respond to say that it will be very difficult to match on all of them per person. So because of that, you've discussed with your statistician, you do the correction at the analysis stage. And how do you correct for confounding variable at the analysis stage? You do that by conducting regression modeling. One of the key reasons why we do regression modeling is to correct for confounding variables. So all those variables, you now put them into the model and to tell us whether they have impact or not. Okay, so yes, we can still do matching based on what I've explained, but don't do matching on so many variables. But when you do so, you run into trouble. Because when you get one unique participant with so many other variables, you must get the same unique variables on the opposite side, which may be difficult. So aim at matching on 1. If you want to match more than 1, don't match more than 2. If not, you run into trouble. So that's what matching is used to correct confounding variables. So these days, people expect us to match. But for me, I even prefer not to match at all. I use logistic regression. Now, we are getting to the end gradually. Sorry for keeping you. So for the next part of the work is a statistical analysis plan. You are supposed to write a statistical analysis plan. please and please and please, don't go through this alone. Right from your proposal stage, consult a certified statistician. The statistician will look at your objectives, whether they are measurable, what statistical tool can be used for them, and advise you appropriately. I've seen people that it is at their analysis or they've collected the data only to discover that what they collected may not be able to be analyzable, and they've spent so much money. So please consult your statistician. Let statistician guide you on what is analyzable, what is possible, and of course, will also guide you on your study, on your statistical analysis plan. Statistical analysis plan is important because if you've already stated what analysis you're going to do, it will be very easy for you when you collect the data. It shouldn't be when you've collected data, you now start knowing that, oh, that this data shouldn't have been collected this way, it should have been collected that way. Now, I remember one thing. If that's the only thing about statistical analysis you remember, please. And that is, whenever you are collecting, you are drawing up your questionnaire, please make sure that your statistical analysis, make sure that all the continuous variables are left continuous. A good example is age. People will say, tell us your age at the last birthday, which can be 20 years, can be 10 years, can be 5 years, can be 2 years. Okay, so you just state the number. So just give a space for them to state the number. Please don't categorize it. Some people say, please choose the appropriate one. 5 to 10, 11 to 15, 16 to 20, 25 to, things like that. That is not appropriate, because if you do that, you have problem being able to handle that continuous variable as a continuous variable again. Whereas if you let it be a continuous, when you collect the data, your statistician can help you to categorize it any way you want it to be categorized. Okay, so don't categorize at the data analysis stage. Categorize your continuous variable at the other end. Now, when you are writing your statistical plan, it's not supposed to be generic. You just carry another statistical plan or someone that just puts there. No, make it specific to your study as much as possible. Make it specific to your study. And from there, I've seen people that from the statistical analysis plan, they want the result to be ready immediately, because you've explained what will be this, what will be that, what will be this, and they'll be happy. And these days, some colleges will want you to even put, dummy tables, which will show you how to get now. So you see this, you can read it later. Because of that, I won't go for that. This is a generic. What is written here is just generic. You just copy and paste from somewhere. Okay. But something like this is specific. Okay. Specific. People can. Anybody that have some statistical background will be able to relate with what is stated here. You can read it at your leisure. Okay. So please, whenever you want to build your tables, dummy tables, or even your final result, please, it's not a difficult thing to do. There are 4 tables that minimum you should just produce. The first table you should produce is what's called a descriptive table. Just show us everything about their population. What's the mean age? What's the frequency of the gender distribution, where they live, socioeconomic status, and all that. So you just have a table that showing us that. Then the next table will compare those ones, all those age, gender, and all the rest. Compare it between 2 groups. We compare it between 2 groups. Okay. So, and we'll be able to use bivariate analysis. Then the third table will now be your actual outcome. If your actual outcome is nitrate, you now check, compare nitrate in HIV versus nitrate in non-HIV. That will be your third table. Okay? Then the fourth table will be regression modeling that you wish to do. So most studies will follow this pattern. So you don't need to put so many chaotic tables and charts that everybody will be wondering, what is this table answering? Which of the objective is it answering? And you can still go by objective and pick each of the objective and draw a table that you know will answer the objective. You can sit down with your statistician to do that. We're almost at the end. Okay, let's just finish up. Then I will share one dummy table for you to see what I mean. And as I said, it works for most people. That same dummy table down. So for budget, please note that you need to itemize all the budget, all the equipment and everything. I noticed for some people, they'll be writing figures in round figure. Please avoid round figure as much as possible. Write the expense, maybe it's 34,350. Don't say 37,030. My God, when you keep adding up almost a figure, people will just feel you just sat down in your room and confabulated it. Not that you actually went out to the market to find out the cost of those things. Okay, and you are supposed to, you have two columns. One is to justify the final answer. Don't just say test kit, 1 million. No, how did you arrive at the 1 million? We arrive at it by saying, okay, 450,000 for 50 kits, and we need, our sample size is 100, so we need times 2 equals to this. You know, things like that. Okay, I should always be in a tabular form. And after you've done that, the next question on the mind of the assessor is that, who is going to fund this project? So if you are the one funding it, you say so. If you are the one funding it, if you have sponsors, you say so. But if you are the one funding it, then you must be careful about your study. If it is too expensive, the assessor have every right to reject the study. Okay, so you must be careful about the funding. These days, by the time you are doing a study that is more than 2 million naira, some assessors are likely to reject it. That is too costly, it's not cost effective. So this is also part of what you should put there, propose dissemination of results. Then when you get to limitation of the study, please, limitations are not difficulties that you can surmount. Limitation, like that, some people doing proposal, they say cost is a limitation. Cost is not a limitation, because you are likely to be able to surmount it for you to finish up the study. Since you'll be able to get funding to finish up the study, it's no more a limitation. Limitations are difficulties that you know that you will not be able to surmount throughout the study. But in spite of those limitations, you still feel your study is worth doing. And one of those common limitations with cross-sectional study is that sometimes you will not know which one will precede the other. Is it the exposure that came before the outcome, or the outcome that came before the exposure? So sometimes you may not know, because it's a point estimate, you are checking everything at the same time. So that's one of the limitations of a cross-sectional study. But you can't overcome it. You may never know whether it is exposure before outcome before exposure, as compared to maybe a core study, which you are sure you are starting with the exposure. Okay, so for such is a limitation based on the study design you've chosen, and you write it there. But any limitation that you can overcome, please, it is no more a limitation of the study. Like sampling technique now, it could be a limitation because most of us we use consecutive sampling technique instead of using random sampling technique. And we know that random sampling technique is the best. So since we are not using the best, then it's a limitation of our study. So ethical consideration, please just note it. your study must commence only after ethical approval. You must be able to tell us how autonomy, beneficence, and all that affect your study. This one alone, ethical is a enough 3-hour blowout that if we want to start discussing it. But you should just know what autonomy is all about. It talks about confidentiality, believing that each individual have every right in the world to decide to do whatever they like. So you cannot force any patient to participate in your study. You must respect them all through. That's what autonomy is talking about. Beneficence means that your study should, if it is possible, be able to benefit your participant. There are some participants, there are studies like randomized trial, drug trial, in which part of what we'll be building is that you must make sure that even after your trial ends, you still provide this drug for them, things like that. So that beneficial. But if it's not going to benefit those people that you recruited, just say so. There's no big deal about that. Say it that, well, you can't see how it will benefit them as it will. But if it will, fine. Like if maybe you are training for hepatitis B, and generally they don't do hepatitis B in that location. You say, well, the benefit is that anyone that now knows our status are we still together? Okay, or you start recruiting people based on, say, okay, based on race, based on, no. So don't allow those social influence or based on social status. So when you recruit patients based on such things, then you are going against justice. You must treat everybody to be equal. Okay? So you should be able to state some of this and explain how you will take care of those things in your study. So timelines, please put on realistic work plans and timelines, very important. People want to see it. And you can produce a GNAT chart from it. If you Google, you see a GNAT chart. Then reference style, please ensure you use the appropriate reference style. This one, people, it's a big issue too, referencing. If it's Vancouver you are using, please read. If you read it, very easy to understand. But it's just that people just want to rush through the whole processes. It will take just a day and say, okay, I want to read about how to do reference. It will tell you what and what. Because of time now, we won't be able to go into full details. We tell you what and what you should put, how you should write the names with initials, what to go after that, what to go after that, So this one too is supposed to be a full, but please, one area I would have loved was the demo of Mendeley, but time is far gone. What we do is maybe we may match later in maybe next year or something. Okay. Then appendices. Please ensure that you label your appendix should be labeled as in Roman figure. Appendices 1, 2, 3 to the end. And anything that is in your appendix must be referred to in the main document. Like a questionnaire. When you were talking about procedure, put it there. Questionnaire, appendix 1. When you're talking anything that is you put in your appendix, please ensure that you refer to it in your main document. Okay? Anything that you didn't refer to in your main document need not be in your appendix. That is not useful. Now you are supposed to be able to move from proposal to dissertation. After you finish up your study, please note that the tenses will change. When you were writing the proposal, you'll be using future tense. I will. When you finish the work, please spend good time. Assessors are always finicky and hungry. When you refuse to now change from future tense to past tense, I did. This was done. Yes, so spend enough time during the time you are collecting data to be reviewing your proposal so that you change all those things in the methodology to past tense. Please, they are not always happy when you just carry the same proposal and they still keep saying, I will. Then your results section is supposed to be past tense. Please, there is no 400 participants were recruited. The mean age of our participant was 40 plus 7 years. You know, everything in your results section is past tense. And there is a difference between writing results and writing data. Let me give you an example. Some people will go in table 1 and say 75% of our population were male, while 25% were female. They say that 30% live in rural area, while 70% live in urban area. If you are stating like that, what you are just doing is that you are repeating the data, because that one will have been in the table. But when you are writing results, what is expected to be seen? It's not every time, but to be seen is to say that things like about 4/5 of our participants were male, while majority, while a few of them lived in, by the time you're having less than 10%, that's a few. While a few of them lived outside a 30-kilometer radius to the hospital. You know, things like that. So those are the words you want to be seen. About half, when you are getting something like 50-something%, say about half, okay, or just above half. If it's 47%, you can say nearly half. Okay, so those are, when you are using short terms, then you are writing results. But if you are just quoting the figures verbatim down, okay, that is repeating results, which people are not happy with. Then one other important thing you should note about result writing too, that just keep me now, when I remember I will say, is is that when you use majority, when to use majority, you'll be dealing with at least something above 80%, okay? Or 70-something%. Yes, you can use majority. Majority of the participants were this. So, one very important thing too is that when you are writing, please, we are not very particular about the actual numbers. What we are particular about that you should guide your inference is the percentages. Percentages are more valuable than the raw numbers. If you tell me that 115 of my participants were male, it doesn't make any sense to me. Whereas that 115 may be out of 200, maybe 115 out of 700. Okay? But if you now put 115 over 700, you now get the percentage. That makes more meaning to your work than writing the actual numbers. So please, let's note that. Then the discussion, and then please don't put so many tables in your work all over the place. Make sure most of the tables in your work, they are addressing your specific objectives, because your examiner can ask you, this table, what is it addressing? This table, what is it addressing? So sit down with your statistician and ask that question. Please, this table, what is it addressing? This table, what is it addressing? Okay, except for the first table, which is social demographic characteristics, that one you want to know. So if they ask you what table, this table 1, what is it addressing? You say that I just want to show the study population, that one. But from table 2 and all the other charts, try as much as possible to make sure it is addressing a particular objective. And please note that you are not expected to show what you've shown in table as a graph or chart. If you are showing it as a chart, then you not show it as a table. That's the standard thing, but though sometimes change, but that's the standard. Try to work with that standard. When you get to result discussion, the core thing you want to see when you are discussing is that the first statement is to restate your aim again. This study was conducted to evaluate the impact of glucose of HIV on glucose tolerance in pregnancy among diseases also. When you've stated that, you now go on to say the result of the main findings of these studies are, state them. You now pick each of the main findings, discuss it, state it, check literature to see whether yours is greater than where it's lower or greater or the same. If it is greater or lower, find reasons why it is so. Is it because their own population is different from yours? If you check well, you'll be able to see. If there is none, you say, well, you can't really find, but you mustn't be saying you can't really find every time. Because if you look well, you see reasons why it's so. But if you read the other discussions too, you see some more of those other papers too, they tell us why there was difference between the exams. So you'll be able to compare your results. Is it the same? Is it low or high? And why is it low or high? If it's the same, you don't need to tell us why it is the same. Okay? Sometimes maybe because of the tool you use. Somebody may use PCR, another person may use antigen test, things like that. The study population, all those things. So when you've done that, the next thing on that same one singular result you picked, you now tell us what pathophysiology, what explanation can you give to explain that result you found, okay, based on your knowledge of that field. So when you've done that, the other thing is, what is that the implication of this, which is almost like the recommendation. So while reading through your discussion, I will have been having an idea of what your recommendations are likely to be, okay? So that's what you write, and with that, you have finished 1 or 2 paragraphs on a particular finding. Then you pick another finding again. One thing people do is to now turn discussion into another literature review. They will start by, even the first paragraph, they just start writing, as if they just went to copy a part of the literature review and put in the first paragraph, just writing all sorts of things. The only thing you need to write in that page, just state that this study was aimed at, so you refresh us about the aim. From there, you go to the main findings. We don't want any other story. You've said that anybody that want to know more about this study should go to read the previous work, previous things you've written, not in the, so it must be potent and avoid quoting so many figures, numbers from your result in this session. Use more of those discussions. Your discussion should be more of those results. When you say about 1/3 add this, So those are the things you should see more in your than writing 45.3 versus 17.3 p-value of the no. Reduce all those. We've stated them in the result section. You've stated your result. Now we are saying, how will you explain the implication of this result to a market woman? Okay, so make your discussion as simple as possible and not as technical for most people to be able to follow and understand. So that's the, now for recommendation, it is important for you to put recommendation in your work. And it's not important that it must be many, whether 2 or 3 or 1, no problem, but just put. And when you are putting recommendation, don't put recommendation that is on your mind. Your recommendation, we must see it live, coming out from your result. Any recommendation that is not from your result, please don't be tempted to write it down, because your examiner will check that this result, this recommendation, is it from any of the results you've stated? If it's not, that's where you will start from when you get into the exam hall. Okay, so don't be tempted, just state the recommendations based on the results of your study. Sometimes your study will be saying it's not statistically significant. You get to recommendation, you now be recommending things that will show as if it was significant. No, if it's not significant, recommend based on say it's not significant. Okay, and one other nice recommendation you can make is to say people can do feature research can still be done. Maybe multi-center study can be done to validate what you found, or there could be some area that you didn't cover. You cannot say it can now be covered in future studies. So always recommend feature studies and tell us what feature study, not just a feature study should be done. What type of feature study should be done based on where you stopped. Based on where you stopped. So I think that was my last slide.
Nothing is showing, sir.
Yes, it's because I think we are at the end actually. Yeah. So this is the last slide for the day. So the last slide, which was missing now, is to just say if there are any questions. So I thank you for your sustained presence at this webinar. We have up to 40 people. I think we started with like 50 something, and we have up to 40 here today. Perhaps maybe my not coming early discourage some people, which I'm sorry about because I still have to do some other activities. And I planned, but somehow along the line, it didn't work out for us. So please, I appreciate your presence, both my big guys and everybody that perform. And yes, this discussion can still continue after now. We can still have some discussions. The only issue I have is that I do clinical work, I do research, do statistical analysis, so many research team and all that. So sometimes if you contact me via WhatsApp or email, if I don't respond early, please, you can repeat. I don't mind reminders, because since there are so many requests coming in, I may not be able to handle them instantaneously. So if maybe after one or two, you can't get your reply, please, you are allowed to. So I saw this now. What's your take on the use of EndNote as compared to Mendeley? We are so grateful, sir, for this wonderful presentation, sir. Yeah, for EndNote, for the last comment, thank you very much. I'm happy about the feedback that the organizers have been able to work together for us to be able to help at least some people. Thank you, sir. Thank you, Dr. Nolapo. I'm grateful, sir, for your comments. So just to finish up what I'm saying along that line. So please don't be worried, don't be bothered. If I didn't respond on time, please, you can always send me reminders. And from there, you can take it up. So if there are questions, please, the floor is open for questions, remarks. I know some are already in the chat box. Yeah, I saw with the issue of Mendeley and EndNote. For me, I don't see any strong reason for picking one over the other. In fact, one is even open source. Mendeley is open source. EndNote is not. So, but if you can afford the bill, fine. But if you not, you can still make do with Mendeley. Nobody even taught me Mendeley. And then I learned Mendeley on my own and I've been using it. So that's why I always feel it is better. Before you start writing, please learn Mendeley. Learn one, because by the time people start making corrections of your work and your references start changing, it's a whole lot of work. But what will make life easy for you is if you have your referencing in one of the reference managers. Even if everything changes, all what you just need to do is to just go and click refresh, and everything will rearrange itself. Okay. So originally it wasn't easy for me. I was always doing manual, but the day I learned how to use Mendeley, oh, my supervisor for my master's said she will not review my work unless I go and learn Mendeley. And I was like, oh, this one is difficult. But at the end of the day, I thank her for making me learn it. It's been very useful to me all through it now. So I will suggest that you learn it, but if not possible, maybe sometimes next year we can still find a 2 hour, no, even 1 hour is enough to work on referencing and reference manager. But just take the book by the horn, can watch YouTube on Mendeley desktop, and it's free online. You can download it, and it's a software, so it won't spoil. Just download it and start playing around with it. Watch YouTube, and you get it, and the time is worth it. So we will appreciate if we can have the slides, including the sample size calculation. Yeah, you can. The only issue I have with my slides these days is that plagiarism is on the rise every day. I see my work somewhere, somehow, and it causes me headache. When you see that this is your work, somebody have now turned it around to become a money-making venture, but it's a risk, so I will still share, no problem. We'll still share, okay? Yeah, so please, I should propose tables be included in the proposal. If you have a good table, which you call dummy tables, why not? Let me see if I can show one. Yeah, that'll be one of the last things we are doing. Thank God I remembered. Yeah, so you see, this is a good dummy table. This table 1 here is both table 1 and table 2. Please, can you see my screen?
Yes,
Hello?
sir.
Yeah,
Yes, I can see.
So this table 1 you are seeing here is a combination of table 1 and table 2. Table 1, just see my cursor, should just be this line, this, and the total. That is table 1. You shouldn't have a p-value, it's just descriptive. Just have this and the total. That's table 1. Then table 2 is where you're now comparing all
We can no longer hear you, sir.
I hear you.
We can no longer hear you.
Maybe he got a call. I'm sure he'll get back to us. Please hold on while I try to reach the facilitator.